for letting us in. And
live streaming is on.
Right, okay. I'd like to say that this is the second day of the inaugural conference of the Global Psychiatric Association. I think we would like to prove the point that we can give interesting scientific talks to people who are in all parts of the world. Today, we will have 5 talks, and it's the first one is an interesting talk about the presentation of community-based psychiatry in the elderly, the Japanese experience. And I'm pleased to invite and see Professor Ucho and Naoki Ucho. And I would like to let you know that he's counsel of the Japanese Association for Home Care Medicine, director of the Society of Informatics to Human Cognitive Disorders, director of the Network of Clinics and Citizens Supporting Home Care, and advisor to the Alzheimer's Association in Japan. And it's a Fukuda branch, and I'm very pleased to hear his talk. Please, Dr.
Okay, thank you for kind introduction. I'd like to start. Wow. Okay. Can you watch my slide? Okay.
Yes.
Okay, I will start. I'm very honored to have this opportunity to make presentation on this conference. Today, I will make presentation about community-based psychiatry and optimal mix services for mental health. I am a psychiatrist and my subspecialty is a geriatric psychiatry. I'm involved in home medical care. These are today's contents. First, I will introduce about background to the promotion of home medical care in Japan. Second, I'd like to talk about the role of psychiatrists in home medical care. Third, I will show you a pyramid for an optimal mix of services for mental health. Next content is about the advantage of telemedicine in home medical care. And last, I will talk about community-based approach. It was politically decided about 30 years ago to promote home medical care, and in the past 10 years, concrete mechanisms have been developed. I'd like to introduce you background to the promotion of home medical care in Japan. There have been several surveys on where people would like to spend the last days of their lives, and more than half of the respondents said they would like to spend it at home. On the other hand, in terms of the actual place of death, about 70 years ago, 80% of people died at home and about 10% died in hospitals. But this has since reversed, and now about 80% of people die in hospitals. One of the reasons behind the promotion of home medical care is a public desire to spend their final days in a familiar place. This graph shows the changes in population estimates for Japan. As is well known around the world, Japan is a society with a large number of elderly people. Light blue represents the population between the age of 65 and 74, and purple is the population aged 75 and over. After the super-aged society comes the multi-death society. This graph shows the estimated number of deaths in my town. It is known that the number of deaths will continue to increase in the future, and the green area indicates that there will be a shortage of hospital beds if we try to provide end-of-life care in hospitals at the current rate, 80%. The second reason is that insufficient beds in super-aged and death-ridden society. This slide shows annual trends in number and rate of deaths. This bold is the period of World War II. Immediately after the war, many young people died, mainly due to infectious disease, but later, with the development of public health and medical care, living longer became the norm, and the majority of those who died became the elderly. This slide shows the changes in the age of structure of hospitalized patients. In the past, inpatients were mainly young people, but now inpatients are mainly elder people. This slide shows changes in the age structure of outpatients. As with inpatients, outpatients used to be mainly young people, but nowadays they are mainly elder people. A young patient suffered from a single disease, visits a specialist, is cured of the disease, and returned to society. On the other hand, elderly patients may be cured of one disease, but have other disease. In addition, there is a functional decline that comes with aging. In other words, there is a limit to the medical model of cure, and a medical model of cure and support is needed. We need a paradigm shift in medicine. The third reason is a paradigm shift in medicine is needed. For these reasons, it was politically decided about 30 years ago to promote home medical care, and in the past 10 years, concrete mechanisms have been developed. The basics of home medical care provided by physicians are regular home visits and emergency home visits. Regular home visits are that comprehensive health care with 1 to 2 visits per month as planned. Emergency home visits are that 24 hours a day, 365 days a year, with temporary visit as needed. Supporting life at home or in nursing homes from the medical aspects by combining regular home visits and emergency home visits. About home medical care in the field of psychiatry, there are 15,640 home medical care clinics nationwide, but only 630, which is about 4%, advocate psychiatry. Of the patients receiving home visits, 93.5% are over 65 years old, and 79% are over 75 years old. For this reason, dementia treatment has become an important field in home-based medical care. There are many psychiatric beds in Japan. How much is more? About 20% of all hospital beds in Japan are psychiatric beds, and about 20% of all psychiatric beds in the world are psychiatric beds in Japan. The number of clinics advocating psychiatry is increasing year by year, and there are about 7,000 clinics nationwide. The current state of psychiatric care in Japan is mainly inpatients or outpatients, and as a psychiatrist's career, he often works at the psychiatric hospital or an outpatient clinic. This is ICD-10F code, as you know. It has something in common with many of the diseases listed here. What do you think? Many mental illness makes it difficult to go to the hospital, when they become severe. How do they treat patients who don't want to come to the hospital and the clinic? Currently, family members go to an outpatient clinic to get medicine or forcibly bring them to a psychiatric hospital and force them to be hospitalized. Prescribing without seeing patients should be avoided, and we want to reduce the number of forced hospitalization for patients who don't want to be hospitalized. In this sense as well, I think it is important for psychiatrists to provide home medical care. I would like to show you a case report on home medical care. He was a memorable patient that I took care of soon after I started working in home care. At the time of his first visit, he was in his 70s. He had suffered a stroke in his 60s and had been visiting a nearby clinic to take antihypertensive and antiplatelet medication. About 5 years ago, he started refusing to go to the hospital, saying, "I'm fine." And then his dangerous driving and daily drinking became more prominent. As the dangerous driving and daily drinking became worse, the troubled wife consulted her friend. She is care manager. When the care manager asked me to visit the patient, I initially thought that the patient might get angry and turn me away. But when I actually visited him, he was in a good mood and welcomed me in, like this smile. Then I asked him about his life history, and when he told me about the time when he was active in his work, he showed me a lot of certificates. He was calm during the medical examination, and I thought that his wife was overstating her case when she said that he was easily angered. However, when the topic of alcohol consumption came up, and he said, "I only drink about 1 can of beer every day," his wife interrupted him and said, "You are lying. You drink 4 to 5 cans every day." Then he became very angry and shouted, "You shut up." I understand this situation is always repeated. I took his blood pressure and showed him the high number of blood pressure and told him that he needed to take medication to lower his blood pressure and that he needed to take antiplatelet medication to prevent the recurrence of stroke. And he agreed to take the medication. I explained to his wife, and this was happening due to the symptoms of dementia, including his increased drinking, and gave her practical advice on how to deal with it. Since then, he was continued to live peacefully at home, visiting the daycare center every day. Many patients refuse to go to the hospital, but are well accepted for home medical visits. I think there are two reasons. They don't have consciousness of disease, but they have a feeling illness. They don't have consciousness of disease, so when their family are told that they are sick and should go to the hospital, they refuse to go to the hospital saying, "I'm not sick." However, they do have a sense that there may be something wrong with them. So if we visited them and explained to them that they needed medication for this and that reason, they would accept home visit and medication. The second reason is that there is a problem with the hospital system. In order to visit the hospital, you need to make appointment in advance, prepare your insurance card, and a medical examination ticket that varies from hospital to hospital. Then, on the day of the visit, you have to wait at the reception desk, wait in front of the examination room, be examined by a doctor in a short time, and wait again for payment. In addition, you have to go to another place, the pharmacy, to pick up your medicine. Thus, it takes half a day to make a medical visit. The hospital system is designed to make it easier for the medical staff to work, not for the patient. I thought that being old, weak in the legs and back, and having cognitive decline due to dementia, they would not want to go through such a difficult hospital visit. I think about the role of psychiatrists in home medical visits. First is that visits to provide medical care for dementia and mental illness. As I have already mentioned, many mental illness, including dementia, make it difficult for patients to visit hospitals when they become severe. For this reason, it is very important for psychiatrists to visit and provide medical care. Second is that establish a therapeutic relationship with the healthy part of the patient. Not everyone will be accepted if physician visits patient. In fact, we often find that a patient is rejected by the internal medicine physician who visited them before us. But they accept us when we visit them. We believe this is because we, as psychiatrists, are trained to form a therapeutic relationship with the healthy part of the patient. In home care, families and caregivers are often faced with the problems due to BPSD, behavioral psychological symptoms with dementia. BPSD is the most common reason for admission to a nursing home. When a psychiatrist visits the patient and sees BPSD occurring, it is easier to understand the situation and respond to it. Families and caregivers of patients with dementia and mental illness are easily exhausted. Providing support for them is also an important role of psychiatrists. As I have shown, home medical care by psychiatrists is very practical, but it is inefficient because doctors have to be moved. In order to deal with this problem of inefficient home medical care, we introduced the telemedicine. Fukuoka City Government, Fukuoka Medical Association, and Tetsuyu are collaborating on a project to improve the function of primary care physician in 2017. This gave me experience in telemedicine, and I was also involved in the development of Yadok. It's an online medical care system. Based on the findings of this project in 2017, telemedicine was covered by medical insurance in 2018 in Japan. The biggest advantage of telemedicine is that you don't have to move. This advantage is gained by the patient when used in an outpatient setting, and by the physician when used in a home visit setting. The telemedicine made it easier for us to decide whether or not to go for an emergency call. In many cases, I receive a consultation over the phone and judge that it is okay from the information obtained there. However, rather than simply telling okay by phone, Okay, by looking at the face through video chat gives patients and their families a greater sense of relief. As I mentioned, many mental illness makes it difficult to go to the hospital when they become severe. So home medical care is useful for mental illness. And telemedicine is also useful for mental illness. This is a text about integrating mental health into primary care, provided by World Health Organization and World Organization of Family Doctors. This figure from the page 16 shows the pyramid for an optimal mix of services for mental health. In this pyramid, higher the pyramid, the less frequently it is needed and higher the cost. The top of pyramid is long-stay facilities and specialist psychiatric services. Psychiatric hospitals and clinics are there. This part is the psychiatric services in general hospital. It is liaison and consultation services. Our services are community mental health services, this part, and primary care services for mental health. I would like to make home care a common option in the psychiatric field. Psychiatric patients should be able to choose not only between inpatient and outpatient care, but also home care. And we want to make it commonplace for psychiatrists to choose not only to work in a psychiatric hospital or an outpatient clinic, but also to work in home clinic as a career option. As shown in this pyramid, primary care services for mental health are an important area of frequent and low-cost need. I provide psychiatric care in the primary care area through home health care, and I continue to give lectures and write articles and textbooks on dementia and psychiatric disorders, because I believe that it is important to inform physicians in physical medicine and other professions involved in primary care about dementia and psychiatric disorders. There are the flyers for the lecture I gave, and I gave a lecture about once a week. These are just some of the papers and books I have written in the last 2-3 years ago. In this way, I believe that it is an important role to pass on the knowledge of psychiatry, not only within the field of psychiatry, but also to other fields of medicine. In addition, as a community-based approach, I feel the importance of working beyond the medical industry. There are two ways to perceive disability support, the medical model and the social model. He cannot walk and use a wheelchair, and there is a place he wants to go on the stairs. When we think of reducing disability here in the medical model, we think of reducing the disability of not being able to work. In other words, we think that we can rehabilitate him so that he can walk and go to the top of the stairs. On the other hand, when we think in the social model, we think of changing the environment. In this case, the idea is to change the environment so that wheelchair can go up a slope. It is thought that disabilities need to be approached from both sides, the medical model and the social model. How to perceive disability support on medical model? Cause of disability is the eyes that can see, the ears that can hear, the limbs that can't move. Thus, removal or reduction through treatment or rehabilitation is necessary for resolution. They think disability is things to remove. They think people with disability are disappointment who have failed to overcome. They think people with disability are to be pitied and protected. How to perceive disability support on social model? They think disability is not only caused by the physical, intellectual, or mental disability of the individual, but also in relation to the social environment. When you suffer from dementia, decline in physical functions due to aging can be described as a physical disability. Cognitive impairment can be described as an intellectual disability. BPSD can be described as a mental disorder. When dementia is developed, all three disabilities according to the traditional classification may appear. If we consider the concepts of the medical model and the social model as they apply to dementia respectively, we should keep focusing on areas that can be improved. Dementia occurs cognitive impairment and interferes with daily activities. If we think by medical model, it is important to improve collective cognitive dysfunction such as delirium and to detect and cure treatable dementia such as hydrocephalus. If we think by medical model, we think change environment by individual or independent support and change the way society should be. A history of trial and error in the effort to create a comfortable society. A society has been created when it is easy for the majority of society to live. A society in which people with dementia will become the majority is coming. It is said that there are currently about 5 million people with dementia in Japan, and the number will continue to increase for some time, exceeded 10 million by the year 2060, according to some estimates. Therefore, it is necessary to create a society in which people with dementia can live comfortably. Because on this social model, we declared a dementia-friendly city in 2018 with a variety of stakeholders, including the mayor of Fukuoka City, the president of the Medical Association, representatives of the Family Association, as well as top executives from industry. This is me. I would like to introduce you about DAA, Dementia Action Alliance. The UK has been promoting dementia-friendly communities since the development of the National Dementia Strategy in 2009, a platform for the participation of people with dementia, their families, medical and nursing professionals, government agencies, as well as corporations. Collaborative development of a variety of dementia-friendly services. We made Fukuoka City DAA preparatory committees starting in June 2019, meeting regularly with a team of staff of local administration, caregivers, and medical professionals. Study sessions are held every 2 months. More than 50 companies from various sections including infrastructure, transportation, telecommunications, retail, finance, and education will participate. As the activities have taken off, a press conference was held in June 2021 to officially name the Fukuoka City DAA as Fukuoka Orange Partners. This is a sentence from a homepage of Fukuoka City. Fukuoka Orange Partner is a consortium of people with dementia and their families, companies and organizations, medical nursing care and welfare providers, and government agencies to voluntarily know, think, connect, and act about dementia. Our goal is to think about what we can do to live as ourselves even after dementia, and to link this to actual initiative. This bag was developed by a company participating in Fukuoka Orange Partners. The bag is easy to use even for people with memory impairment, with large pictures showing what to put where. Also, this apron can be easily worn without tying the strings at the back. This is a scene at the daycare center attached to our hospital. A company is in process of developing a bag and apron, and we asked people with dementia to actually use them and give us their opinions. In the past, the process would have been to talk to dementia specialists and develop a product. However, the original process is to listen to the opinions of the people who use the product. In the past, we thought that people with dementia would not understand what we were talking about. However, they are fully capable of expressing their opinions if we devise a way to communicate with them. In order to develop a product for people with dementia became monitors. This is a job that only people with dementia can do. Orange Human Resources Agency is a system that connects companies with people with dementia who want to work. She was present at the press conference and is a person with dementia. She used this system to work at a bookstore once a month. She said, it's important to have a purpose in life. I'm glad that I have more energy in my life. I have been looking forward to this day once a month. When I was offered the job, the first thing I felt was surprise and happiness. I want to do whatever I can do now. That's all I can say. This is conclusion. Home medical care is being promoted in Japan as the number of the elderly and the number of deaths increases, making home care a common option in the psychiatric field. In many cases of mental illness, it is difficult to go to a hospital or clinic when the illness becomes severe, so home care and telemedicine are effective. When we think of the pyramid for an optimal mix of services for mental health, the current psychiatric care is too biased toward specialized care at the top of the pyramid. In the future, I believe that psychiatrists need to increase opportunities to collaborate with other fields and communities beyond the boundaries of their specialty. This is community-based psychiatry. Thank you for attention.
Yeah, thank you a lot, Professor Ushida. I think we have some questions from the internet now, and
Okay.
it's are you ready for that? If you can put your screen on.
Okay, let's start.
Put your camera on, that'd be nice. So the question comes from Daria Ahmed from Iraq, who is interested in Japan. He said, in your mental health care, system, do you provide structured group psychosocial activities for patients in order to boost well-being and resilience? Professor Ushida.
Yes, we have a group. So our clinic have 7 psychiatrists and 7.
Please, can you put your camera on, please?
Okay.
Thanks a lot. Thank you so much. I think it's easier to listen for.
Okay. Actually, we have a team because my clinic have 7 psychiatrists and 7 physicians. So every day, was 7 to 8 doctors go around our city and with nurses. But it is a little bit rare case. Mainly, mainly most clinic only have a 1 doctor, so it is a little bit difficult to make a team. But they make a team by the other company, for example, the nursing team or the home helper team. So it depends on the situation.
Right, thanks a lot. Another question is: it seems the mental health care is more medical orientated. How are your concerns on mental health and psychosocial support and psychotherapy for elderly with cognitive impairment? So what is this? So let's say what is the weight between this is my understanding of the question. So what is the weight between the psychosocial care, psychotherapy? Do you do psychotherapy in the elderly? What do you offer?
Okay. Psychosocial therapy is maybe going to them by psychiatry and talk with them is already psychosocial therapy. And we also talk with their family, and we also talk with their caregivers. That is like a psychosocial therapy. And on the other hand, psychotherapy for the dementia people is a little bit difficult. Maybe there are, but for example, in our daycare center, we have a group psychotherapy with the dementia patient. And we use the power of group therapy. We make psychotherapy to a dementia patient, but it is only the trial. We try to make a presentation and we try to write the paper about group psychotherapy to a dementia patient. But it's new therapy, I think.
I can remember we tried some of this when I was still in Germany, so trying to do group psycho, and I think I think as we said before that you can integrate people with dementia quite a lot, but you have to also think about the way they communicate. The other thing is how do you deal with the comorbidities? People with dementia sometimes have depression. They sometimes have other problems. I think dementia itself is the ground, but we have BP, so behavioral problems. We have depression. We have aggression. So I think how do you deal with that in the home setting? So.
Oh yeah. In the home setting, we can use the same medication in the clinical setting. So if we need it, we can prescribe the medication. So we can deal with the depression or delirium. And in many cases, we should reduce the medication because the multi-medication is occurred delirium or many side effects. So it is important not only prescribe the medication, but also reduce the medication is very important.
Yeah. I think in the early parts of your lecture, you told about this large amount of hospital beds. So in Japan, I think, maybe you can explain that. You said you have 20% of the hospitals or hospital beds in the world. So there must be an immense resource of psychiatry services. And, if you I think in the UK, they transferred some of the hospital services into the community. So I think you should have an awful lot of resources if you have these large numbers of beds. So can you explain that?
Yeah, it is very big challenge because there are many psychiatric beds, so patients can enter the hospital easily, and many psychiatrists worked at the hospitals. So many psychiatrists' career is in the hospital, and actually, so most psychiatrists don't know about home medical care. It is a problem, but in fact, tomorrow I will be speaking at the symposium at the largest conference of psychiatric clinics on the topic of home care and telemedicine. Little by little, I'm getting more and more requests to talk about home care at psychiatric meeting. And I feel that psychiatrists are becoming more and more interested in home medical care. It's challenging.
Okay, thanks. Maybe I can just add another question. About the whatever other. You said you have an awful lot of people in the older age. So what do you do with people with Down syndromes? So what we get in here increasingly is people not just dementia, but I think in here is a gap in early onset dementia, alcohol-related dementia. So sometimes, or drug-related dementia, or let's say physical health-related dementia, chronic people in chronic dialysis. So sometimes I feel that these people with these physical or drug-related or addiction-related problems fall through the net of not being Alzheimer's or not having a vascular dementia. So is there any concern about that? Or how do you manage these younger onset multimorbid dementia cases?
Yeah, we can't divide the treatment of mental illness and physical treatment. So in the home visit setting, we should treat both physical and mental illness. So it is very important. And in Japan, geriatric people received the home medical care is the reason because the geriatric people is the cost is covered by the health insurance. So they should pay a little bit percent or only the 10%. But in the younger age, they should pay the 30%. So it is difficult to receive the home medical care on the younger people.
Right.
Yeah.
So they still fall through the net a bit.
Yes.
Right. I think there was another, and I just don't want to keep your time too much, but I think you said something, the hospital is not made for the patients, it's made for the doctors and the nurses and the stuff. I found this a very, very interesting point. And, working in hospitals, I always thought it's complicated for me and enough. And I thought, it should be more streamlined for, let's say, the doctor's purposes. But you're absolutely right. We are working for patients. And the question is, how can you improve a hospital? Is there simple ways, in a way that you can say, okay, we have, waiting times, and, that's one thing. So we have, corridors full of patients waiting left, right, and center. So the question is, how does it work, to have a hospital which is focused on patients, but not on the medical team, or manages both? So how would we reorganize the system?
It is very important question. If there are fewer patients, the hospital will change. Yeah, but it's a little bit difficult situation, I think.
So you're not giving us advice on that.
Yeah, because for example, Japanese Association of a Psychiatric Hospital have a big power, big political power, uh, because they have a history and they have many members. So it is, I think it seems a little bit difficult to change the big association.
Right, okay. So you're not too optimistic. Okay. Professor Ushida, I think you gave us a great insight into the Japanese system, and I think I'm really thinking you gave many people some ideas, and I'm very, very grateful for this very exciting and interesting talk. Thanks so much.
Thank you very much.
I am very thankful, Naoki, for your presence. You are most welcome to a Global Psychiatric Association, and I hope we can count on you on future events. Thank you very much.
Thank you very much.
Okay. Bye-bye.
Bye.
Hello, and welcome back to the Global Psychiatric Association's first inaugural Congress, Mental Health in a Globalized World. Now I want to introduce a good friend of mine,
Global Psychiatric.
Professor Rainer Hune. He is not only our very beloved president, but also he is a doctor, consultant neurologist, a professor of psychiatry in Mainz, a professor of psychotherapy in Bonn, a professor of OA psychiatry in Birmingham, and an editor of the Global Psychiatric Journal. A good friend also, as well. And he will talk about how to write a paper, a hypothesis-based approach.
Okay.
Now, welcome, Professor, and please go on whenever you want.
Yeah, thanks a lot for listening. And if you can bring up the first slide, then be great. Can you bring up the slide? I think one of the ideas of the Global Psychiatric Association and Global Psychiatry is about to improve the ability and help people publishing papers. So in this respect, we would like to have a better approach to deal with publications and manage. I'm getting a bit confused, So anyway, so the idea is that we help people publish papers, and I found that a hypothesis-based approach is very much helpful for people, because I have been learning this by myself. I have been working in multiple sclerosis, and I found it very difficult at some point in time to find out what other people want to read. And I swapped a little bit from an approach which more or less was writing everything I find possible to be written about a subject, to a problem, to an approach which is more based on a hypothesis, and in this respect is respecting the thinking and the way the reader thinks in a better way. Can we just go to the next slide, please? So the question is, you have different aspects of a paper, and you have the introduction, you have the methods, you have the results, you have a discussion, and this also has to be summarized in an abstract. Some people start writing the abstract first, and it makes sense to some extent, because you just have to focus on your most important take-home messages. So that could be something where you could start with, because it gives you some ideas where you want to go. So, however, the introduction is usually developing and stating the hypothesis at the end. So let's say that way you have different aspects. You have, let's say, you want to talk about schizophrenia, you want to talk whatever, the family and poverty and inequality. So you would develop that and possibly talk about schizophrenia. You would talk about the impact of poverty. You would talk about another paragraph about the impact of the family. Then you would possibly put another issue together about family and poverty. And then you would say, okay, how does it affect the patient? And then you could ask, what is it you want to show? You could say, okay, long-term poverty, by social inequality leads to schizophrenia, or it's making it more severe, or it's affecting the care. So trying to develop and state the hypothesis at the end, that's the most important part of the introduction. The methods describe how this one hypothesis, which I then mentioned, is tested. And the results should describe the sample, how would we collect the data, what were the analyses, but most important, what is it that we could do to reject or support the hypothesis. So we should answer the question we put at the end of the introduction. And the discussion should then state and confirm or refuse the hypothesis, or should validate it, and also explore the relevance of the finding. We very often read papers and say more research is needed. But But that doesn't help very much because there's always more research needed. But we would like to know, what have you found out in a paper? What have you done? And how can you use your data to improve future research? Okay, and if you do this in the abstract, you give 1 to 3 sentences from each section in a structured way, which usually fits a journal. It could be objective, material and methods, results and conclusions. Other have background, but it doesn't really matter. The important part is that when you write an abstract, you can easily focus on the hypothesis. Next slide, please. Next slide. Okay, so the introduction. So first you go to the background, you go for the first issue, might be social inequality, you go to the second issue, which might then be poverty, and then you come to the third issue of schizophrenia. The order doesn't really matter. You would then try to combine that. We wouldn't try to, try to do everything you can find in the papers. You would try to combine that and try to manage to get this in a meaningful way. And then you would develop a hypothesis based on that. Right, I don't know. So, okay. And then you would finally try to name a hypothesis, and you can do it in a form of aims, or you can ask a question. And the question is how to clarify what you are going to investigate. Usually I try to do this in different types of paragraphs, one idea, one paragraph, and then you think about a red thread going through the story, and you think about the reader. Next, please. Next slide, please. Okay, so the role of the introduction is more or less leading to the hypothesis paragraph by paragraph, introduce the disease, the concept, or the objective, introduce the relevance of the disease. Why is it you can mention why is it important? Because it hasn't been done properly, hasn't been done in your country, hasn't been done under the same circumstances. And then you have more or less developed hypothesis. Next, please. Usually you have lots of stuff in the material and methods. So more or less you have to ask yourself, what is it what you want to show? What material or sample or people do you need? How do you collect material or recruit the sample? How do you get the patients? Where do you get the patients? And usually it's a question that the readers would know, is this a special sample? Is this something where you can really answer the hypothesis? So let's say we come back to this example of social inequality, schizophrenia, and family. Then you would possibly say, how representative is your society or this group of society? Is it just a study of family or a group of families which live in specific circumstances, maybe rich, maybe poor, or how representative is your sample? And this is what the reader would know. Are there any controls? What methods do you use, to answer the question, to get information? Do you take bloods? Do you analyze bloods? And if so, how? What type of blood analysis do you do? What type of interviews you use? And how, usually in the material and methods, people would expect how valid are your methods in relation to the hypothesis. So the question is, what did you do and what do you have to do that your hypothesis that there is, let's say, family in poverty affects the treatment of the patients? Then you have to look at the treatment of the patients, and you have to know what have you done to assess your hypothesis. The one important thing is about the quality of the material and methods is, can an independent researcher reproduce your study? So you don't need to explain it to everybody, but you would usually say, if someone who wants to redo your study, does he know enough about what you've done? And the other thing is, you might have not an independent researcher, but you might have a general reader, which might be a psychiatrist. So the question you ask yourself, does this person would have enough information to be convinced that you did the right thing. Next, please. So the question comes back to the hypothesis. Where and when was the hypothesis tested? In which sample was it tested? Which instruments and outcome did you assess? How were your methods applied to get an answer to your hypothesis, which can be generalized? How have the raw data been analyzed? What statistics did you do? And finally, what did you do? What type of analysis did you do to validate or falsify your hypothesis? Next, please. In the results section, you would possibly say it's what is your main finding, and you would maybe have one or two hypotheses, and you would say, I assessed, come back to the example, I assessed the true quality of treatment, which you would have been defining in the methods. You would have to say what type of families there were, and what type of measurements you have made to your poverty. So you would describe your sample, and then you would have a paragraph about what is the main findings, and then later you come to additional results, maybe some results you haven't expected, and in many cases we find additional results. It should be mentioned in the study whether you have results which are related to your hypothesis and studies which might be unexpected but interesting. The question being is usually the question is a trust of the reader. Can he understand that these were your aims? And this is where the question comes with the hypothesis. Next, please. Next, please. So you should, in the results, describe your sample in relation to the study, describe your results or step by step, focus on the main results which are related to the hypothesis, and then say, has your hypothesis been falsified, been supported, or have the results been unclear about that? There are many studies about medication where the results are not clear. So the question is, then you have to say that. If that's said in a proper way, there's no problem publishing a paper. Next, please. Next, please. So in the discussion usually starts with a short paragraph of reiterating the main findings by your hypothesis. You know, what were their samples? What have you found out? Then you try to compare it with other authors. Is there someone who is this your finding? Let's say in that way, the poverty in family deteriorates the treatment outcome. Then the question, do other people have found this in other studies? That could be studies in other diseases, it could be studies in depression, but it could also be studies in other physical health problems. So the question is your study, is your outcome of your study consistent with other studies? What are the differences? So let's say there might be differences in males and females. Usually what you find very often that female schizophrenics have a slightly better outcome. So the question, is this related to gender? Is this related to the social roles? Is this related to the integration of the family? Then the question is, are your results valid? Have you found that, can you support your results, or are they not totally clear? Have your methods been sufficient to prove that? Have you had the right methods, or what could you have done better? What are then the meaning of the results in general? Right? So what are the meaning of the results for the patients? So, and finally, you come to the limitations. So the question is, can you talk about all families in the world, or can you only talk about a specific group? Did you find only very limited people? That's very common at our current time of the computer-based or online questionnaires, where you're not totally clear which sample you have addressed, who did you reach. So then you come to a take-home message. What can you do with your finding? What is the specific recommendations for future research? Next, please. So coming back and focusing on the hypothesis. So You state the confirmation or refusal of your hypothesis. You explain how the hypothesis was validated. What was the outcome of your hypothesis? How does it fit with other publications? What does it mean in general and in specific? Where were the limitations of the analysis? How can this type of validation or falsification of the hypothesis be used for future testing? How would be the next hypothesis look like? So what is the questions people might want to answer next? And I think the more precise you are what should be done next, the more people can learn this, and they will also cite your paper, which would be nice, you know. Right, if you come to the next. Okay. I said, I spoke about the abstract of a patient's. Usually try to give the 1 to 3 sentences and a summary of each section structured in objective material methods, results and conclusions. And be clear about the fact that the objectives or the introduction develop and state the hypothesis at the end. There's no point saying, okay, we looked at families, but people want to know which one is the question or which one is the aim. Yeah. So very often, you know, that we get very specific, very general aims. This study is to do, let's say, a review about mental health in families. So that's possibly a bit too general, because you know you can't look at this. But what you should then say, you come up with something more specific. Under which circumstances, in which sample. So your hypothesis shouldn't be we look at something. You should be very clear what type of study and what type of hypothesis you are looking at, and then focus not saying I've done this, I've done that, and we calculated something, and we did this test and statistic. You should write more or less clearly how were the hypothesis tested. So what instruments and what methods did I do to provide evidence? So you would say we recruited so and so many patients with their families who lived in different living conditions, and this is then we assess the most important questions, which is maybe treatment outcome or well-being, but that's a different cup of tea if you go for well-being. Let's say we focus on treatment and then you say treatment outcome. So then you would say, no, you know, you measured this, that, and the other. You would say, what is the hypothesis? It's treatment outcome. Then you should say, how did I measure the treatment outcome? Right, and the same is, you know, for the results. Describe the data collection and the analysis that lead to the rejection or support of the hypothesis. And maybe if there's, you know, you have something very interesting, gender differences or age differences, please mention it, but please mention it that this is exploratory data analysis. And the conclusion should be state and the confirmation or the refusal of the hypothesis, how it was validated, and explore practical and future relevance of the finding. So after, next please, after you've written a nice little paper, you would want to publish it. This is just to indicate and memorize where is the flow of the papers. So the introduction and the methods lead to the hypothesis. Then the methods help you to make sure whether it's true or false. Then you get the results and the discussion. So parts of the study leads to the hypothesis. Yeah, next is fine. So sometimes I think it's good to reiterate what's very simple. Introduction, what's the relevance of the question? Methods, how to answer the question. Results, what's the answer to the question? And discussion, what is the relevance of the answer? Right, next please. Next please. You know, I just, there's very nice, this is from the PRISMA study, and this is focusing on meta-analysis. I just want to go quickly through more details. And I think it's sometimes very, very helpful to have these checklists. But these checklists sometimes can be very confusing because people try to put everything into the checklist. The PRISMA criteria are quite nice. and they come up with ideas what you should do. You should, let's say it that way, when you do your introduction, you should discuss the PCORS criteria. In this respect, we're talking about systematic reviews. And one thing is also that you into a systematic review, that you identify the report as a systematic review. And sometimes it's quite nice to have something as a result, so in the title. So instead of saying this is a systematic review on the influence of poverty on the family and the schizophrenic patient's treatment, you would then possibly say a positive outcome and saying, okay, systematic review revealed that poverty in families negatively affects the treatment. So then people who want to read your paper are already knowing that what they're talking about, what can we focus about, and this is very, very helpful. I talked about the structured summary. You should have the background. You should have, and you should focus on what your journal is. There's nothing more frustrating as an editor of a journal to see that this paper has been written for someone else and has been recycled on several occasions. So try to structure it in the same way as the journal likes it. And yes, take your background, take your data sources, look at your participant, your interventions. Very, very often people do not describe the interventions or the questionnaires. They do not explain how they have recruited people, whether they're a specific or a very general sample. Then in the introduction, try to focus on the rationale for the review in the context what's already known, and provide, and this is not my ideas, but it's also idea here from this Prisma group, provide an explicit statement of the question being addressed with reference to the intervention, comparison, participants, outcome, and study design. And then you can go through all these things, how did you sample, what were your, let's say, focus on a paper on the issues, what are your criteria to include a paper, what are your information sources, where do you get the, whether is it PubMed, is it Medline, sometimes you have to search in specific areas when it's not in the mainstream. Then you would present how you possibly used your search strategy. And you just, some people, when I see this very often, and we have, when we have junior doctors doing papers, sometimes they put something in the discussion where they start, where they put something in, where they should have put something in the methods. They come up with the idea, the questions to this specific questionnaire, or the answers to this specific questionnaire were very vague, or were indicated this finding. This should already be in the methods. So the method should be something which someone else who reproduces your study, who reproduces your systematic review, can use to organize. Then you go with the study selection. Which studies did you include? Why did you include them? How did you screen them? And it's very important also to say, what have you not included? The question is very, very difficult sometimes to do meta-analysis. Some people always ask me, why is it so difficult to do meta-analysis? The problem is that people, if there have been 3 or 4 randomized clinical studies, there's no really many incentive to redo a study. So in this respect, very often systematic reviews are more helpful. And we have published studies over Ramadan, simply a Ramadan in mental health, or football and mental health, or criteria for subjective memory impairment, where a systematic review wasn't possible, because simply people haven't thought about using or repeating studies. And most people come up with a new idea instead of trying to reduce studies. The only area where studies are very, very often redone is in pharmacotherapy, where the same medication is checked in more or less the same type of samples. But in other areas, which are more social, psychotherapeutic, this type of repetition of the same study is more or less the exception rather than the norm. Okay, you should describe your data collection and the way you analyzed it. There's sometimes, you know, some papers or journals are quite keen on the possibility of bias. The question is, some people take checklists for that. Be careful about a checklist, because sometimes it doesn't really represent your study, and it's sometimes more or less clear that better to give a question about why you think these studies which you present are not representative. So we had, you know, when we looked at, sometimes you had a study with Dr. Impe where we looked at the ADHD and suicide, and what we found very, very often is that there is no generalized information about the population. What people very often published were the very, very specific samples in very highly specialized organizations such as prison, and then looking at suicide, which is all right to do that, as long as you don't generalize to the general population. Okay, so I'm saying these formalized checklists are very, very helpful, but look at what your study is doing as well. Can I go to the next? Juan, can I go to the next slide, please? Hello?
Hello, can you see the
Yeah,
following one?
Go to the next slide, please. I can. Yeah. So this is now how to publish a paper. Just go. This is the link to our journal, Global Psychiatry. Next, please. So the question is, when you want to publish a paper, there are different reasons, you know, and you should, you know, it's not everybody wants to write something. Talk about motivation. What are the resources? What are the contents you can focus on? What type of paper you want to write, and what do you have to do before? Then we go to different parts of the paper. We'll talk about authorship and resubmission and proofreading. Next, please. Next, please. Thank you. So why do you want to write a paper? What do you want to achieve? So people, you know, say, oh, I want to write a paper because I want to write a paper. That's fine. But usually the question is, what do you want to do? Do you want to inform the world about your special case? Do you want to make an impact? Do you want to improve your career? Do you want to move to academic work? Do you want to write something for your own fame or your grandchildren? Are you unhappy with something? Do you want change services? Do you want to do something you're unhappy with? Do you want to promote a specific type of service or community service? Do you want to help your patients in general? And I think this is important to find your own motivation, not just the least to consider whether whether you can go through all this. You know, I don't know, some people are very much career orientated, some people are more interested by issues which they're not really happy with. So that's something you should possibly spend a couple of hours to think about that, because that will keep your motivation going. Just saying, oh, I want to write a paper is usually a difficult approach, because what happens very often, then this gets out of your way. But if you say, I'm unhappy with this type of service, then it motivates you to do something. Okay, next, please. The other thing is, so apart from your medication, it's what have you got? So I think sometimes you have to rethink. You know, you don't have everything. You might have a case where you think this is very special. At the moment, which is possibly, which I would recommend, is very much look at data sets. There have been so many large data set produced that people really underestimate the quality of data sets and the opportunities. So sometimes, if you, I would like to give an example of that. I looked at, recently wrote a systematic review for global psychiatry looking at OCD and suicide. And, I got this usually, looked at the paper, looked them up, and what I found was that many studies were focused on OCD clinics. So they had a higher rate of suicide than the population. So the question is this a question that people who have only looked at the very difficult patients, or who comes into a clinic are the people who are suicidal, the ones who are admitted to hospital? And the interesting part of it was that you couldn't find a conclusion. And whilst I was writing this paper, I was a bit frustrated about the impact. And then in 2017 there came another paper out looking at, and this was a Spanish guy who looked at the Swedish register. So he looked at people who have been in hospital in any time in a Scandinavian country, and then they looked at a register of suicides. And looking at, so these data then, they're very clear that people who had OCD, not when they were admitted to hospital, but when they were diagnosed, had over the next 40 years 5 times an odds ratio of 5 times risk of suicide. So this is contrary to some of what we learned at the university, because we thought, people with OCD in the clinic said they don't kill themselves, which might be true, because at the end of the day, suicide is a very rare event, and people might not be very honest about that if they tried it. So the question is very relevant. Can you access a data set? And sometimes it's much more helpful to help the progress of science and clinical care by using an already there data set. Do you have a completed study? Do you have a study? Do you have interest in research? Do you have ambition? Do you need to write just to get your job done, or to get an extension of your job? Next, please. Next, please. The question is also, people should look at their resources. Some people say, I can write, let's write a paper in a couple of weeks. But if something can be written in a couple of weeks without preparation, I promise you it has already been done. The question is, what you also would need is a bit of a resilience. Sometimes it's quite helpful to get a secretary or someone who supports you, because there's nothing more frustrating than formatting things and struggling with your language if you have a secretary who possibly might do the same stuff in much quicker time. The other thing is, do you find someone to coach or supervise you? Do you have a senior colleague? And sometimes it can be very difficult, because you might find a senior colleague in hospital, and what we see, or what I see very often, they come up with fancy ideas. They haven't looked at research for years, and in this respect, they come up with fancy ideas which already have been done a couple of hundreds of times, and they waste the times of the students. So if you look for someone who should support you or would support you, look for someone who has published and see what he has published, and whether he was someone who is successful. Some university people might provide you access to data, access to files. Do you have access to a statistician? Let's say it that way. That can be a limiting factor. So if you want to do something which is whatever needs a specific statistical requirement, you might need some support. So the question is, even if you do something, look at the resources you have, because there's nothing more frustrating than finally having a lack of resources. Next, please. Next, please. The other thing is, where do you work? Do you work in a practice? There's no point trying to compete with a hospital, university hospital. Do you have outpatients clinic? Look at your own strengths. Do you work in a hospital? Do you work in a general service? Do you work in a special service? Then you use your resources. So there's no point looking at other, very general issues in the general population. If you just work and see patients in a very specialized organization, let's say in a prison, then you just, you should, or in a prison service, then write about the prison service. So sometimes people very often come up with something which is not their area of work. If you're interested, that's fine, but we're not all Einsteins who work at a patent office and come up with a relativity theory. So that's something you should consider. Most people, including myself, they can better write about something which is in front of their own nose and which they can discuss with other people. There's something weird, there's something saying that usually 7 people who are normal people, normal doctors, are much more clever than 1 professor. So sometimes it's also good to have an environment of people who can help. Next, please. Could be in a university. The question is, what story can you tell? So if you have a case, what is interesting in this story? What is special in this story? What type of story can you tell? Is this story is this a story of whatever? I don't know. Can you just come back? So what is new in this story? There's no point saying, people with dementia, they can't read read a book. So that's nothing interesting. So the question is, why would someone want to read your story? Why would one or a journal take their pages, spend some money on this, and want to publish it? Why would you think that this case must be known? Is it something which makes you tick? Is it something you feel it's new? And let's be honest, there's so, if you look at the normal textbook, there's so many things which you can be changed. So the question, what you have to take to, why do you have to make the effort to write your story? Next one. Right. If you want to write a story, do your literature research. Discuss it with someone senior researcher. Discuss your issue with someone senior clinician. Discuss it with colleagues. So they might have ideas you don't have. Next, please. The other thing is, when you write something, think about your readers and the editors. Why would they want to read it? What would people think when they read it and agree with the publication? So think about an editor, think about a reviewer. Does he understand it? Think about the publisher. Most importantly, think about the reader. Which journal do you want to write for? Are there occasional readers like the BMJ who look in everything? Are there journals which are subscribed and you just look at the people who have a general continuing interest in academic work? Do you think you write for the co-researcher who do that? Or do you write for someone who you want to motivate to become a follower or future researcher? Thank you. Next one. So then the question as a type of paper. Usually people want original paper, which are research papers, but that might be difficult in the beginning. Others are case reports. There's so many people writing on case reports, which are quite difficult to publish. But then they're journals for case reports. There's special journals for review paper. And sometimes, even you can write short reports, which are not in any journal, or if you have something very exciting, you can write a rapid communication. You can write a letter to the editor or an editorial, but that's very much depends on the type of journal. Next one, please. Okay, so we already mentioned parts of the paper. Usually people come up and forget when they prepare paper, look at the cover page. People want to know something, and sometimes it can be very difficult. If you submit a paper and it's always called manuscript, you drive the editor crazy. Look at the journals, the author's introductions. What are the types of references they know? What type of acknowledgement they know? they want, what type of declarations of interest are relevant. Next, please. Yeah, so yeah, I said this already. Next, please. Next, please. So where to submit, you know, so let's say that way, if you have something which is of regional interest, then go for a regional or national paper. If you think you have something which is of international interest, then focus on that. So there's nothing, let's say it that way, but then you have to focus on the reader. So I sometimes say, if you want to publish in a general international journal, then you should write for the Greek, the Chinese, and the Australian reader. So there's no point saying, okay, I write about my city and what happens in my city if I can't really consider other areas. And so look at the objective, look at the readership of the journal, and look at the impact of the journal. Is it read? Is it valued? And sometimes it makes sense to look at the previous content. Have they published about something? At the moment, you know, there's like Global Psychiatry, we're quite happy to publish about something about COVID, but let's be honest, after a while, COVID is too much. So you would also like to have other papers as well. So it's not possibly, so let's say it's nice if people publish about COVID, but it could be too much already, or it could be something which hasn't really mentioned in the recent journal, and they focus on that, and they're quite happy to publish, let's say, about new types of psychotherapy, then go for that. But you so make a bit of, you know, an editor usually would want to give a little bit of variety in contents. Next, please. I think I'm running out of time here. Make sure that the authorship is mentioned so that people.
No, don't worry. You're fine. You're fine. We can keep ongoing.
Okay, thank you. So the authorship is about drafting a paper, writing a paper, providing information, providing materials. It's about getting sponsorship, it's provision of data, provision of samples, helping with the paper, and also doing the proofreading. And I think, you know, you should also, if you are the first author of a paper, do not let the co-authors run away with everything and say, okay, you're part of the paper, but you haven't read and corrected or drafted the paper itself. So I wouldn't agree with that. And, you know, this is what comes up more and more, that authors have to clarify what type of information or what type of contribution they've made. So if someone hasn't done, let's say, contributed to all steps, more or less, the design of a study or the development of a study, the performance of the study, and the writing up of the study, then they shouldn't be really authors. They should be in the acknowledgement if they help, but, you know, there shouldn't be hundreds of authors in one paper. Okay, next, please. Next, please. So if you submit a paper, look at the format. You know, there's nothing more frustrating for a journal than having the literature in Vancouver style, and then not, you know, having the Harvard system, and it's very, very frustrating. I tell you, it's really frustrating if people don't look at the author's instructions, and at least, let's say it that way, if you submit a paper at the first time, people more or less would look at the contents. Is this something which makes sense? However, if after your first review and you're asked to revise some part of the paper, really at the latest look at the author instruction, because that's really frustrating if people have to have 4 or 5 revisions simply because they can't be bothered to look at the right to the format. Look at the forms you have to add to your paper. Look at the agreement by all your co-authors. Make the right declaration and write a decent letter to the editor to make sure that he understands what's special. What is it? Why he would want to do that? What is special in your paper? And you come back. What was your hypothesis, and what did you find out? Next, please. Next, please. If you correct and resubmit, look at the editor's decision. And there's nothing more frustration that people say, we reviewed the paper and don't give an answer to the reviews. So the question is, prepare a response to the editor and say, this is what I want, prepare a response to the reviewers. So sometimes it's very, very difficult to look for the first, as an editor, to look for the first version, to see what the reviewers have written, then having a revised version of a paper, and nobody knows what they have changed. So the question is, then you have to go to the old version, check it with the reviewers version, see what they've done. And this is something which some editors, sometimes including myself, simply says, if you can't give a point-by-point answer of the concerns of the reviewers, then we just do another review, because it's impossible. So so the question is, give answers to the reviewers, give answers to their concerns. You can reject them and give a good argument why their recommendations were bad, but give answers point by point, and don't forget to transfer your answers or your changes into the paper by rewriting it. Next, please. Next, please. Yes, we very often have problems with proofreading. This is the last chance. After that, there is no correction possible for the next centuries. Any mistake, your fault as an author. That's the way it works. And if there were questions to the authors in the proofreading, clarify the questions, answer them properly. There's no just saying, okay, I put that in. The printer sometimes, don't expect that the printer is understanding what you do. They're not having no clue what you're talking about. They want to know which letters they turn, which paragraph they change, or which sentence they change. But they're not expected, and you can't expect a proofreader or a printer to read the whole paper to make sense out of a very flimsy remark. So make sure that someone who has no clue of the paper can do the changes. Next one. Next, please. Right. Worst case scenario is rejection. What next? Okay. You accept the rejection, put it in the bin. You can complain if you really have a good argument about that. The argument is not about, you're not nice editor. Say, maybe this was, the reasons was for the rejections. I can amend them. Try to understand where they're coming from. Try to improve it and try to resubmit. So don't get angry and say, okay, it took so long. And if a review, let's say it that way, if I'm a reviewer and the paper is very difficult and very fussy, then I'm very unhappy to look at the paper. So if I get a clear paper which has been nicely written, takes me a weekend. If I have a paper, where everything is confusing, nothing really answered, the review is not, the answers to the reviewers are not totally clear, then I get rutty and I just put it on the side and take other papers first. So try to be positive and try to take the answers, give appropriate answers to what the reviewers and or what was the reason for rejections, and try to take it to the next journal. Next, please. Right. Okay. So I possibly might have frustrated you, but if you're still full of ambition and wanting to write a paper and publish a paper, let me know. You seem to have the resilience you need. At least you have listened. Thanks a lot, and please support the Global Psychiatric Association by joining us. Next, and if you want to submit a paper to Global Psychiatry, here is the link. Thanks a lot for listening, and Juan, if there are any questions.
Okay, excellent presentation, Professor. Let me stop this screen sharing. Okay, we are cool here. Okay, we have some questions from the audience. Well, the first one is, how do you support young scholars from underprivileged countries? I'm eager to be a part of your academic community.
Right. Okay. So let's say it that way. What we're trying, let's say it's a very general question, but I'm happy to answer that. we are trying to, the Global Psychiatric Association, to be a little bit of like an NGO where we can support other people. We don't have to grow to be old and see psychiatry for 20 years. So I think we support young researchers, and we try to make connections to other people. And maybe in the near future we will. And one of my ideas would be to have a conference where maybe people who want to finish their papers want to discuss it with other people. The other thing is, if you want to submit a paper or work with global psychiatry, we had people who were having struggles from their own countries, and I'm quite happy to support. I think the editors of Global Psychiatry are quite happy to support. Sadly, sometimes it's a difficult process. Sometimes we made proposals for how to write a paper. We send them some information. I have a collection of information about our papers, how to write a systematic review. So let's say it that way. If you have any questions, just take the website or contact me or other editors of the journal if you have questions. They usually, if you look at Global Psychiatry, most of the editors are absolutely supportive. They have their emails on the website, so you can contact them. Maybe it's not, we get some support from Norman Sartorius. However, I think this is a busy man, so I think go for the ones who are a bit younger, and they are usually very helpful, and they have learned how to write papers themselves. So I think be kind, be proactive, accept some criticism, accept some ideas, and I think other people are really, very willing to support you. I hope that
there is another. I think so. Okay, here is a question. It is also important to report some psychometric properties of the tools used in a particular study, because they can differ due to different sample, translation of items, etc.
Yeah, I think it's very important to report the validity of your instruments. So I come back. Let's say, did you use, I think if you have a hypothesis, did you use the right tools to answer the question? So are there valid tools? So let's say if you have a questionnaire and someone, you would try to, let's say it that way, you might want to develop a questionnaire because the questionnaire is not available. But in most cases, you would try to convince people with a questionnaire which has been validated. And it's a little bit difficult if you have the Hamilton Depression Scale, which has been, or the mini-mental status examination. You possibly, we are quite happy to let your readers know that this is a validated questionnaire which has been published in 1996 by 1976 by Folstein. That's fine. But if you say, okay, this is a questionnaire which whatever we translated to Bangla, then it's possibly say, how has it been validated? How has it been approved? Has it been translated? Has it been retranslated? So the quality. So you should think about, can a reader, and this is what I said before, can a reader understand that the way you've done it is appropriate and has done the right tools. So coming back to this idea about whatever treatment outcome in schizophrenia, there's no point saying, I asked the father for a treatment outcome. Then more or less, then you don't know what has been done. So the question is, your outcome criteria and the way you analyze these outcome criteria are very valid and important. So you have to think about what other people who are in the field, who might not be experts, but who are psychiatrists, are knowing about that. So think about the young psychiatrist, what he knows about that. Think about the other expert who wants to be convinced about that. So yes, you have to explain why the tool is appropriate to answer the question. Usually it's half a sentence. You can say, we chose this tool because it's a validated instrument to assess mental health or whatever mental health or to assess stress in the general population. That's fine, you can say that. But and it has been validated so and so often in different languages. But if it's not really validated, let's say in a different language, then show and explain why you think it's an appropriate instrument. Thank you. I hope this isn't a clear answer. Yep. Are there any more questions? Right, I don't know. So I would say if there's no more questions, thanks you so much. I think we have to come to our little break and load up the next talk. And Juan, thanks a lot for your support, if it's still there. And yeah, I think we have to get away. I think the streaming has to finish and then Juan?
Okay, now we go into an interlude. Thank you very much, Professor. It has been great having you in here. And next, we go with Dr. João Mauricio Castaldelli Maia. We go into a little break and we'll be right back at you. Thank you very much, Professor.
Thanks a lot. Thanks for listening.
And we are back. Thank
Hi,
you
Juan.
for your presence. Dr. Joao, how are you?
How are you, Juan? Sorry, I didn't hear anyone, so I was
No,
asking myself.
don't worry because you're next. Well, I will take the opportunity to present Professor Joao Mauricio Castaledeli Maia. He is an assistant professor of psychiatry at the Department of Neuroscience at the Medical School. ABC Health University Health Center, sorry, and a postgraduate advisor at the Institute of Psychiatry of the University of Sao Paulo, Brazil. He is a member of the WPA Standing Committee on Education. And Dr. Castaldelli Maia has earned both his MD and PhD from the medical school at the University of Sao Paulo, right?
Yeah,
He's an
exactly.
associate editor of Frontiers in Public Health, Frontiers in Psychiatry, Frontiers in Sociology, and Global Psychiatry. He is also an editorial board of the International Review of Psychiatry, International Journal of Social Psychiatry, Irish Journal of Psychological Medicine, and Current Drug Research Reviews, and the Revista Paraguaya de Psiquiatría and Medicina Crítica y Social. He has published more than 100 pages and edited 2 books, right? His presentation will be the main gaps for randomized controlled trials in psychiatry. So we can begin as soon as you want, Professor. Thank you very, very much for being here with us.
I think I don't know if you are frozen, but thank you so much, Juan. And should I share my screen?
Please.
Okay. Let me get my. Do you get my screen there?
Yes, of course.
Okay, thank you so much. So I would like first to thank Heiner for inviting me and also Juan for being a terrific moderator for this conference. And it's a great initiative. We are in the need of more global conferences on mental health. And today I'm going to present a work that we've been doing for some time. And not only myself, but all the members of the WPA Standing Committee on Scientific Publications. We were together from 2014 to 2017. Heiner was part of it, and I'm going to acknowledge all the members in the end of this presentation. But we were in the search for the main gaps for randomized controlled trials in psychiatry. And I must say that this talk, I think that it will complement beautifully with the last talk.
Professor, you went mute.
Psychiatry. So,
Okay.
if you are sorry.
Your microphone went silent for a moment, but please continue.
Are you seeing me right now?
No, we are seeing your presentation. Don't worry.
Okay. Is it okay? Are you hearing okay my presentation?
Yes, yes.
Okay.
Please continue.
Thank you so much. If you don't hear or any problem that you see, please just stand. So I think that this talk will complement beautifully with the last talk given by Heiner. So, as you must know, psychiatry, historically, psychiatry has been one of the areas of medicine receiving fewer resources for assistance and research, probably due to stigma within the medical field. And much of this disparity between mental and clinical conditions is due to the difficulty of including psychiatry into the medical model of care and research. Unlike other medical areas, the psychiatric diagnosis is complex because of the subjectivity inherent to psychological distress and the lack of biological markers. So the recognition of psychiatric disorders is still subject of intense research. We have the updated versions of DSM and also ICD show great advances in the diagnostic area. So the DSM-5, for example, presents
Professor?
Okay. Hi. Okay.
It's your Wi-Fi all right. It seems that you have a bad signal.
The connection is not good?
No, the connection is not good. Sorry, excuse me, because the microphone is becoming mute from time to time.
Oh, okay. Let me perhaps.
Okay. No. It's all right. It's all right.
It's all right. It's all right.
Yeah, yes.
Okay.
Yes. You can continue.
So let's see, and so we have these new manuals and these proposals of dimensional diagnosis with which is really a challenge, and we have when we bring mental health disorders into the medical model. And we believe that all these manuals make our life easier to get the psychiatric diagnosis inside this medical model. We come to intervention studies. So in our intervention studies are mainly focused on psychotropic drugs and psychotherapies. And when we talk about intervention, we talk about randomized controlled. Randomized controlled trials are the studies of choice. And for the persons that are new to the field, what are the RCTs? So RCTs are studies in which we have two or more groups that are randomized to receive two or more types of interventions in a controlled environment. RCTs are of critical importance to develop treatment guidelines and also of special interest to the pharmaceutical industry. So they are in the top when we are conducting, creating a guideline, or when pharmaceutical industry are defining their targets to develop new treatments and also to evaluate what is effective and what is not effective. So they are really important. And if we have a lot of RCTs, we can do something that is even more interesting and more trustworthy. And we can conduct meta-analysis. Meta-analysis in this sense of the RCTs. So there are several types of meta-analysis, but the first and the most important kind of meta-analysis is when we aggregate RCTs together. And the guidelines are paying special attention to this kind of meta-analysis because we have more and more RCTs being conducted in different countries, but in the same field. So it became easier to do more and more meta-analysis. However, despite we see an increase, and we have a lot of signs that there is increase progress in the number of RCTs. And when we were at the WPA Standing Committee on Scientific Publications, we were really trying to identify these areas, and we tried to do it by doing a bibliometric analysis, an exploratory bibliometric analysis. So bibliometric studies are we are in the beginning of bibliometric studies in the health and the mental health field, but they are really useful to identify some trends of publications. We found some studies with observational studies, some studies with case series, some case reports, but we found that there was a lack of a large bibliometric study trying to address and to identify which are the trends in RCTs. So we in our field of psychiatry. So which are the areas that have more or less during the last 20 years. And this has a lot of limitations, but we must remember that, and we are going to say that, but PubMed, the vast majority of the RCTs are published in PubMed, in the health and the mental health field. We start searching using keywords, and we defined keywords for each of the psychiatric diagnoses listed in the chapter F of ICD-10. Our period of search was from 1999 till 2018. So this was a period. So we know that we had previous to this period, we had ICD-9.
Professor, your connection
We
is
also
unstable.
excluded the subchapter of childhood and adolescence disorders because this chapter excluded the psychological development disorders because this was also very restricted to one group of age. So our bibliometric study is mainly focused on adult psychiatric disorders. And we did a preliminary analysis in March 2016, and our final analysis was in December 2018. And we took advantage of several good filters that we have in PubMed, and I'm going to show you to you here in more detail. But we restricted our search to studies with humans. Then we restricted the search field only for title. And here I must say that you can ask, oh, well, why did you just put the abstract? We put title because we wanted the studies that were a randomized controlled trial and they were defined as it is. So we had, and we used the filter also for clinical trials. And when we also used the filter for the date, we wanted studies from 1999 to, sorry, I must, oh, well, I'm here back again. And so from 1999 to 2018, and then we used the keyword randomized, which was to define that we just wanted RCTs, not other kind of clinical trial. And then we included the keywords. The keywords were for each disorder. We defined the keywords that were the best, and I have in our paper that I can share with you, which were the keywords for each disorder in each chapter. So going to the results, what did we found? And we found an interesting trend. First of all, when we look at the crude distributions of RCTs during the last 20 years, we found that after 16 years of considerable increase in the bioanimal absolute number of RCTs in the psychiatric field and also in the mental and the clinical field, we had a slowdown in the last 4 years. And this trend is in line with the RCTs published in PubMed for all the fields. Affective disorders were the mental disorder group with more RCTs during all the 2 decades. And in the beginning of the period, there were around 100 psychiatric RCTs, which is around 1 in 40 in all the PubMed. And psychiatry peaked at almost 1,200 RCTs in 2015, 2016. So it's more than 10 times higher than the beginning of the series. And from 2007 to 2008 to 2015, 16, psychiatric RCTs were responsible by more or less 1 in 20 of the RCTs, so around 5% of the RCTs. And affective disorders responsible for almost half of the RCTs conducted during this period. What did we find? We had a lot of the chapters that were here together in these curves, and we didn't have a lot of detail here, so we plotted logarithmic curves to see these chapters in more detail. And so we see that organic, neurotic anxiety, and psychological related disorder had approximately similar trends during the last 2 decades. Psychotic disorders was the second most studied psychiatric group with RCTs during the entire period. And in the last 2 years of the series, organic disorders became the second most common psychiatric group. We had for substance use, you see in this red curve, that we had, there was an increase, then a stable period, and then an increase again, and then going back. But we see that is a group that is not among the most studied groups in this area, as you can see. For mental retardation, you see that there is almost no study in all the 2 decades. And the other group that is a little bit more but less studied is the personality disorders group. You can see here, you see it's not like mental retardation, but is also not so studied as the other groups here. You can see in these logarithmic curves. This figure is interesting because we can see by the disorder how the things are, so how they distributed. So we selected the top 20 disorders in the last 20 years, then in the last 10 years, then in the last 5 years, and then in the last 2 years. The colors are the colors of the last 2 years. So you can see the movement through the time frames. So the difference between depression and schizophrenia, which are the top studies, has increased, with the first being investigated more than 3 times the second in the last 2 years. Despite exchanging places, eating, generalized anxiety, and post-traumatic stress disorders remained from the 6th to the 10th places in all the time frames. So you can see here's eating disorders, more or less the same, GAD, more or less the same, PTSD, more or less the same. There was the same situation for drug use, OCD, personality, and postpartum disorders, which remained from the 11th to the 50th place here. So you can see personality, you can see OCD, you can see drug disorders, more or less in the same place. The most remarkable changes were seen for delirium, mild cognitive, bipolar, and alcohol use disorder. So delirium was trending up. So it was here trending up to the top 5 in the last 2 years. For if we get alcohol use disorders, that it was in the top 10 and then was falling to this between the 11th and 15th place. And we can see bipolar disorders coming from 60 to 70 to 8, and now a little bit here in the between 8 and 10. Here in this last places of the top 20, we see some disorders coming on. We see tobacco use disorders a little bit stable here, but we see that we have sleep disorders coming, and also premature ejaculation coming, and some disorders like panic disorders getting out of the top 20, and schizoaffective disorders getting out of the top 20. We have phobias here, keeping stable during the time. And we have sexual dysfunction also very stable in the almost 20, in the 20th position in all the period here. So how can we discuss our findings here? So this was the first bibliometric studies in the psychiatric field to explore all the ICD-10 mental and behavioral adult disorders. Overall, after 16 years of considerable increase in the biannual absolute numbers of RCTs, there has been a slowdown in the last 4 years. And the top groups or affective disorders was the most studied, but followed by organic and psychotic disorders in the second place. And regarding the disorder themselves, we had depression, schizophrenia, and dementia in the top 3. And I didn't talk about dementia, but dementia was here. Dementia and insomnia, they were here in the 3rd and 4th place during all the trends. So I forgot to comment on that. That is really important. Okay. For substance use disorders, there has been a decrease in the last 5 years, in line with the fall of alcohol use disorder in the ranking of the most studied disorders. So this is something to pay attention. We have alcohol use disorder as one of the most prevalent disorders in the psychiatric field, together with tobacco use disorder and also depression and anxiety disorder. So it's a little bit sad to see that we had a decrease, and that we still don't have good, very effective treatments for alcohol use disorder. So this is quite interesting. Delirium and mild cognitive disorder are both ascending in this ranking, which is mild cognitive disorder is a disorder that's more and more recognized, and we see more attention both in the field of diagnostic and also in the field of the therapeutic field. So it's good to see. And personality disorders and mental retardation have consistently been the last studied groups, especially mental retardation. So this is a summary of the most important things that we are going into more detail to discuss why is it happening for this trend. So this slowdown of RCTs follow a similar trend in the entire medical field, and we see that the researchers are searching for possible alternatives to RCTs because they are high cost, they are long duration, and of limited generalizability for the other countries. So real-world studies are really coming. Longitudinal healthcare databases and registries, we are seeing more and more studies. We could see good and bad examples in this pandemic for COVID, but we saw that there was a lot of studies based on, with really large numbers, based on medical electronic health records. And I really personally believe that these studies are the future because they are low cost, but we are still learning how to do it. And in the COVID pandemic, we had, as I said, we had good and bad examples of big data studies using electronic health records. We also have the emerging new diagnoses listed in DSM-5 and ICD-11, which could also play a role in attracting some RCTs, and we didn't capture this diagnosis during the period. So this is something that in the end of the trend could kind of attracted RCTs for them. We had also, there are some authors that say that we have changing and more strict requirements to make RCTs in the last years, which makes really our life really difficult when conducting RCTs. And there are also fewer new drugs coming on the market since the beginning of the last decade. And I was, especially in the central nervous system, I was in touch with some people from pharmaceutical industry, and some of them was they were doing less research. They were no good and promising molecules to go to phase 4 trials. And so I think that now in the last 1 or 2 years, I'm seeing more new molecules coming, but it's true that pharmaceutical companies have been investing less in research and development of new medications. And we had this problem of this, and I'm not here defending pharmaceutical companies, but they had some price controls in some countries, and that allowed they were making less money in some countries, but they are still making a lot of money. I personally believe, and I'm seeing new molecules coming in the last years. Going to affective disorders themselves. Affective disorders, this first place that during the entire trend, and especially focused on RCTs involving depression, probably reflects the extent of diagnosis of depression within the context of common mental disorders. So we have increased mental health literacy. We have more recognition of depressive symptoms by the general population and by the other physicians, not only psychiatrists. We have indications for various agents extending to the diagnostic area, as well the emergence of novel electrical stimulation techniques, this biological treatments, new agents such as ketamine, and a lot of things. So it's a field that we have a lot of options, and I always compare treatment of depression with treatment with alcohol use disorder, and how we have a lot of options when we have patient with depression, and how we have restricted and not so effective options when we have a patient with alcohol use disorder. So it's really a field of and we have a lot of things going on. The organic chapter also had moved up in these rankings, and a lot of these trials focused on delirium and mild cognitive disorders, this moving up, but also with dementia, very stable in the third position during the entire trend. And so we have increasing awareness of these two conditions, delirium and mild cognitive disorders, and increasing emphasis on early intervention for mild cognitive disorders as a mean of preventing progression to dementia. So we have more and more interventions for early intervention. So dementia, we had a very interesting wave of medications for dementia, most of them preventing the bad progression, but we have people given much more attention to identify early signs of dementia. In this context, mild cognitive disorder is really climbing up in terms of interest. We also have a proportional decrease in psychotic disorders, maybe paralleled by increase in organic disorders. I talked about dementia, but schizophrenia remains as the second most investigated disorder. We have several new medications on the market, so there is still a lot of interest in schizophrenia. The decline of alcohol use disorders investigation remains, we found as a public health issue, maybe due to the lack of new medication candidates. We had a lot of studies with naltrexone, acamprosate, also disulfiram, topiramate, but there is not very good candidates by the moment. We had a lot of candidates that didn't show it up a lot of potential, and so this is a field that we think that there deserves more attention. Personality disorders are difficult because we think that there is a diagnostic overlap in terms of clinical features with other conditions, frequent comorbidity, difficult in recruitment and also retention in the treatment, and also the lack of pharmacological efficacy in the treatment. So, and most of the RCTs in our field, they make use of pharmacological treatment. So it's difficult to conduct RCTs. Despite being the prevalence of personality disorders, there is a lot of debate, but a lot of the studies show that they account for more or less 1 in 10 in the population. So it certainly deserves more attention. The RCTs that we found were almost exclusively focused on borderline personality disorder, which is a condition that is a kind of an outlier group. And there are some proposals to classify borderline in another out of personality disorder. So it's something that when borderline disorder go out of this chapter, the situation will be even worse with even less RCTs coming up. We have poor response to the treatment. So it's also something that when we compare to anxiety and depression, it's something that's quite different. We have more or less similar issues that also apply to mental retardation. So mental retardation, we have virtually no RCTs conducting during the time. It's true that there are ethical issues with the recruitment of those individuals, so it's more difficult. They cannot understand the risks involved in a given RCTs, but it's more or less conducting research with children and adolescents, so it's more complicated. But there is also uncertainty around the effectiveness of interventions for this group, but also this also allies with a lack of interest by the pharmaceutical industry. Also, it's a group that really, and I saw a lot of papers asking for more attention, because if there is efficacy of any agents to some signs and symptoms, we really don't know, because we don't have RCTs being conducted. We also comment on the popularity of certain diagnostic categories for RCTs being guided by a kind of a clinical vogue, which could be influenced by a host of factors such as novel treatments and also easy of access to patient populations. And it's not necessarily linked to actual need, as indicated by the prevalence or burden of the public health, or even the public health impact. So alcohol use disorder as an example. And we found some disorders that are based on the WHO treatment guideline on the most important ICD-10 mental and behavioral disorders. Certainly we need more attention to acute and transient psychosis, mixed anxiety and depression, adjustment disorder, dissociative and conversion disorders, somatization, and also hypochondria and neurasthenia. So this is our conditions that are common and are really not studied. So this really is a summary of what we found, what we said here. So the most studied, so we have here, and we commented on that. Even personality disorders are more studied than other conditions here, and you can see. But we just believe that they will deserve more studies considering their prevalence among the population. But acute psychosis, transient psychosis, dysthymia, cyclothymia, acute stress disorder, adjustment disorder, dissociative and conversive disorders, somatization, hypochondria, and other mental retardation, impulse disorders. So we talked about that. Finally, most patients with mental health problems have been treated with more medications and have more mental or somatic diseases. In this point of view, RCTs are not always representative of this population. We have more real clinical patients that are often covered with observational clinical trials. So we have, which are very important, especially in elderly patients with mental health disorders. In summary, there are situations that prevent RCTs to being conducted in our subpopulation. Especially, there are also several barriers to conduct and publish psychiatric research, especially for young colleagues. So when we have in Brazil, we have people that are groups that are not so well known, and they are conducting research with less studied groups. An example, dissociative disorders, and they are not able to have space in PubMed indexed journals to publish their research. So this is something that are also pointed by Coco Beck, for example. So as the limitations, I'm almost finishing my talk.
2 minutes, please.
Okay. The present study used only PubMed database, whilst not necessarily comprehensive. There are other important databases, but it provides a good reflection. It's a very initial exploratory study, and we don't want to give the final word here. We are just inviting more and more studies to come in now. And but if we add other database, probably the results will be the impact will not be so high because RCTs are on average most of them are published in PubMed. And other things are about English language studies. So PubMed really concentrates more English language studies, but again, RCTs are in general they are more studied, more published in English, almost all of them. So this is something that it's also something to be said. So just finishing, despite this increase in the last in the first 15 years, we have in the last 5 years market slowdown in our areas. We also found some areas that are privileged, some affective disorders, psychotic and organic disorders, in detriment of others like substance use, personality, and mental retardation. Regarding these specific disorders, we call for more studies in acute psychosis, mixed anxiety and depression, adjustment disorders, dissociative and conversion disorders, hypochondria, neurasthenia. So these are the kinds. And we call also for clinical researchers and editors of scientific journals to give special attention to this less studied disorder. So when someone do a RCT in a, for example, acute psychosis or mixed anxiety and depression, this is something that must be given a little bit more interest than other conditions. So I would like to acknowledge all my co-authors, Michelle Riba, Michelle Riba from the US, Dusica from Serbia, Prabha Chandra from India, Alfredo Sia from Argentina, Peter Tyrer from UK, Heiner, and also Christopher Zabo from South Africa. Thank you so much for your attention, and I'm open to any questions that we have. Let me go back to our here.
Okay, thank you very, very much, Professor. It was a really insightful presentation. Oh, sorry, excuse me. Yes, here it is. Sorry. It was a really interesting presentation. I think Rainer has some questions for you, and I would like to expand in future events about your research. Thank you very much.
Thank you.
Professor Rainer. Professor Rainer. Excuse me, I think he might have connection issues.
Connection problems, probably.
It seems so. It seems so. Well, it's a shame that he's not available because he.
If you allow me to comment and also share with our friends, if there is not any question, if there is no question, I would like just to comment that the journal Psychiatry Research, they have an open call for studies and on these discrepancies in our field. And I'm not the editor, but I think that this is a call for our audience that in terms of inviting them to comment on that, because as you could see here, there is a lot of discrepancy. There are a lot of more attention to certain kinds of disorders in detriment to others. So I think this is an open venue now for publishing something, original article, or even a comment.
Of course. Professor Rainer Hune is trying to connect. May we wait a little bit for him?
Okay.
If you don't mind. Thank you, Professor.
Juan, are you from Colombia? Colombia?
I am.
Hey.
I am Colombian, of course.
Okay,
You are
okay.
most welcome to our country once this pandemic crisis subsides.
Yeah, it was pity that we couldn't reach because WPA conference was going to be in Colombia, and also I know that people were very sad.
Yes,
Rodrigo,
I was really sad because I was really looking forward to it.
To meeting all the people, and I think it will be a very nice opportunity to meet, also for us to meet.
Yes, of course, but don't worry. I am sure the GPA will hold one of these days.
Yeah.
Yes,
certainly
we will.
a good place to be.
Well, I want to ask you about something regarding your presentation. What about COVID studies?
Oh, COVID studies. COVID studies. I think that we have a enormous amount of studies with depression. First of all, depression and anxiety is the top of in the top of the list. COVID and depression and anxiety, both for people with COVID, both for people without, in terms of the general population, and also now we have a lot of attention to depression and anxiety during long COVID, that we say. We also have a lot of studies going on PTSD and also alcohol use. People in the United States, they have a lot of data coming, and we have interesting data coming, and they are showing that the suicide rates are decreasing or decreased during the pandemic, but the overdoses rates are climbing up, and we are seeing more and more studies focused on alcohol and drug use disorder. So this is something that I think that they are coming.
Oh, okay. No. It was my system. Don't worry.
Okay, but I see that. I see a lot of studies of intervention studies coming on depression and anxiety, and also in PTSD, and more recently on alcohol and substance use disorders. People are really drinking much more during COVID, and this is a public health problem that we really should pay attention, because we will pay this price in the end. We know that substance use is something that really it's really difficult to deal with.
Yes, and normally it would have long-lasting consequences.
Yeah.
In the individual and as a public health problem. I also believe that, as I have some experience
it's like
working in addiction worlds.
Yeah, a wrong way of dealing with all the situation, all the bad moment that we live, and all this stuff that we live. But we should really avoid it. But I'm happy to see more and more studies coming in the next years.
Thank you very much. I think Rainer had some issues connecting, but he's back with us. Or Professor, whenever you want.
I can say thank you, and thanks very much. And I think this COVID stuff is very interesting. And I think, we possibly have to move into general health in general, instead of having this whatever ICD-10 focused approach. So I think that, like, society issues, that's not something which is very difficult to assess. And we yesterday had this very interesting talk about trauma, and there's some stuff. The question is whether these issues are amenable to RCTs. childhood trauma. Is the time of RCTs run out to answer very important questions, society issues, migration, war, racism, and all these lots? So how can you do this? Do we need long-term study, or do we need to go to large clinical databases instead?
Yeah, very good point, Rainer. Very good, and congratulations again for putting this conference up, to you and Juan. I believe that we will have more and more observational designs for all these conditions, because RCTs, we create a really artificial environment to conduct RCTs, and these are good. It's not. These are still the gold standard study for in the medical field, but I'm seeing people doing more and more big data studies with electronic health record studies, using very sophisticated statistical techniques to make them more similar to RCTs. And one of these techniques is propensity score matching, which is a really interesting technique, because you get observational design studies, these samples, and try to address scores, propensity scores, trying to kind of transform these studies and balance. People will receive it, some kind of interventions, and people who not. We are still improving our skills and learning a lot. And in COVID, we saw, as I said, good and bad examples. But I really believe that this is the future. This is the future, and these kind of studies are much more real-world studies. And trying for me, for Juan, we see sometimes some RCTs that are conducted in high-income countries, and it's really difficult to get this to our kind of settings that sometimes are very poor. Not all the settings are poor in Brazil and Colombia, but some of the settings are very poor. So it's really interesting to see this kind of statistical techniques helping us in dealing with this kind of more non-controlled designs.
Okay, I think thanks a lot. You can join us for the rest of the for Juan's talk. I think it's coming back, but we have a quick break, haven't we?
Okay.
Thank you very much, Professor.
Thank you, Juan. We should meet in person when we can.
I will look forward to that. Thank you.
Bye-bye.
Hello, can you hear me?
Yes, I can hear you.
Right. Okay. So it's. I think it's really a blessing now to introduce not only our technical whiz and expert, but Juan Evangelista Tercero Gutan Buitrago. I hope I got the pronunciation right. And
More or less.
yeah, and he is vice president of the Global Psychiatric Association. He's a specialist in addiction medicine, a psychiatrist. He's fellow in dementia and cognitive impairment in of the Argentinian Neuropsychiatric Association. He's honorary member of the Argentinian Society of Personality Disorders and Psychotherapy. He's international fellow member of the American Psychiatric Association, member of the chapter on psychoneuroendocrinology and the chapter 5 of evidence-based psychiatry of the World Psychiatric Association. And I'm absolutely looking forward to his presentation, Current Operative Foundations of Informed Consent in Psychiatry. Please, Juan.
Thank you. Thank you very much, Rainer. Well, I am very happy to be here. I hope that the audience is satisfied with the quality of our presentations. We have put our hearts into this event, and I hope you feel the effort that we gave it. So, well, without further ado, I will start sharing my screen. Okay. Okay. Yeah, let me see if I have. Can you see it?
Yes, I can see it.
Yes.
I can see the slides.
So
Yeah.
now it's full screen. Okay, it's on the full screen. Okay. Well, the current operative foundations on informed consent in psychiatry. It's a very special topic for me because it's part of a research I did when I was a psychiatry resident some years ago. This is very important in my opinion because psychiatry is treated differently than other specialties. There is a saying in Spanish that in psychiatry the client does not have the reason. This means in a commercial sense when you say that the client it's always right in psychiatry. Normally people think that the client is not. Now there are some problems that must be faced or must be taken into consideration when you talk about informed consent in psychiatry. First, that it's a fundamental part of medical practice, regardless of the specialty. Both GPs or other medical professionals are compelled, and the ethical norm uh, demands that they give information to obtain the consent of the patient. But in psychiatry, there is some kind of misinformation that our patients are mostly psychotic, which is completely false in my opinion, are not able to take decisions on their own or to have any saying or any word in the process of their treatment. Yes. Well, as you know, our current situation with informed consent derives from a heightened respect for the autonomy of the patient in the medical practice. The patient has taken an active role in decision making. Psychiatry is not the exception. And remember that there is a growing tendency of lawsuits against medical personnel in the whole world. I haven't heard any colleague around the world that has not said that he or she should be careful or should not be careful of lawsuits. All medical practice nowadays is fundamented in some grade towards a defensive practice of medicine. Psychiatry is not the exception. And I need you in this introduction to understand this because psychiatry is also a medical specialty as any other. Of course, I know the audience may already know this, since this is an event geared to, or suited for mental health care workers, but there is not enough repetition of this concept. Now, in the past, the physician held some sort of almost religious consideration from the people, from the public. Including here in Colombia, there is an old saying that if you wanted to be the authority of a town, you had to be or the mayor, or the sheriff, or the priest, or the doctor. Now, with more population needing medical attention, with more population having unrestricted access via the internet to medical information and healthcare information, and a growing tendency of these social network influencers to give unlicensed medical advice, this social standing of the medical practitioner, of the physician, is something of the past. We are workers as any other professional around there, and in the eyes of the population, the doctor is someone else, just as a clerk, an engineer, or a lawyer, or any kind of profession. This puts us as psychiatrists and as medical personnel into a heightened risk of lawsuits. Okay. Now, why is it important to take into consideration the foundations of informed consent in psychiatry? Because there is a misconception that psychiatry is a different branch of medicine, different to any other medical specialties. I already said this, but as I said before, there is not enough repetition of this concept. Now, not every psychiatrist is a psychotherapist, but there are many psychotherapists that are psychiatrists. And note that a psychotherapeutic intervention, a crisis contention, de-escalation, is linked to a risk of a malpractice, of an adverse outcome. Yes, most of it derives that psychotherapy is geared to produce permanent changes in behavioral and cognitive patterns, and they are susceptible to be dysfunctional after the intervention. Now, all psychiatrists are entitled to formulate pharmacological interventions. Now, if you remember yesterday's talk from Matej Stujek, we are prone to multiple mechanisms of action and also a lot of potential for adverse interactions and even adverse side effects per each medication. And we are using 1, 2, 3, or many medications at the same time, directed to treating specific symptoms. Take into account that there have been many divergent postures regarding diagnostic systems in psychiatry. So we have the defenders of the European school of the ICD or the DSM, or now there is a small but growing tendency to support the research domain criteria diagnostic approach. And even there are many who still consider valid older and more historically relevant schools of diagnosis, the diagnostic approaches. All of them are valid, in my opinion. All of them have something to give to the medical, to everyday medical practice. But take into account that some diagnostic approach may differ significantly from another. And even if we are using with our colleagues the same diagnostic system, there is a really high intervariability among the professionals. Okay, so this also comes with the fact that if the diagnosis changes, the treatment changes. The therapeutic approach even may be different for the same diagnosis. There is another problem that comes and is relevant to informed consent in psychiatry, and is that we as psychiatrists are really dependent on long-term adherence. Our treatments have a slow onset of action and produce perdurable results only if the treatment is taken for enough time. I need to make a contrast with other branches of medicine and other specialties. And a normal treatment for a pneumonia or a urinary tract infection might be most tops 15 days, 2 weeks, 3 weeks tops. Our treatments are meant to be taken for months and even years. So, not having a good communication with the patient, not having the patient to understand why we are doing this and what are we going to expect from the process, from the intervention, from the pharmacotherapy, might impede this patient to understand why long-term adherence is needed, and we will miss many opportunities to make a positive change in the patient's quality of life. Also, there is a huge problem. The general public does not understand mental illness properly. And again, I want to give some criticizing to this access to this misinformation coming from social networks, because there are many influencers that think that recommending a patient, a severely affected patient from a mental illness, to take a walk to the nature, to have drink some concoction, or eat or have some specific nutritional diet may have an impact in his mental illness, which is not, because mental illness ultimately is the expression of some kind of brain dysfunction for the more biological oriented psychiatrists, and obviously has a huge social and personal subtract, some social and personal foundation that has to be taken into account and must be an important part in the individualization of every therapeutic approach in every patient. In psychiatry, there is no one size fits all approach, and I'm sure you all know this. Informed consent is the way in which we tell the patient what this specifically tailored approach will be, and what will we be considering, what will be the therapeutic objective. Now, what is an informed consent? Many people think that it's just a paper you get the patient or his caretaker to sign in order for you to do whatever you need to do to improve the patient's health. This is not true. And if we go to the specific dictionary-led definition, we can see that there is a permission granted in full knowledge of the possible consequences, typically that which is given by a patient to a doctor for treatment with knowledge of the possible risks and benefits. This is somewhat the official English translation of what is an informed consent. It's interesting that specifically we are dealing with the doctor-patient relationship, even in a textbook that it's not meant to be a medical reference. Now, if we go to the Spanish definition, I am Colombian, so I am a Spanish speaker by nature. The literal translation is this one: consent that is given from the ill, or if not possible, his or her caretakers, before initiation of a medical or chirurgical treatment, after being informed by the physician about the reasons and risks of such treatment. I really like this definition. This is an unofficial definition of the Royal Academy of the Spanish language. Well, unlike other languages, Spanish has a dedicated entity to revise definitions of the dictionary and to revise the application of the language. This is interesting because, excuse me, okay, because we are faced with two important factors. One is that there is an information about the intervention. This is meant for me to tell you that there is an universal consensus of the information about the intervention, the benefits, the risks, and the reasons. And of course, it's important that you all know that risks does not imply a certainty, but a probability. Yes, we are dealing with the odds of success, of having an adverse event, or having any kind of adverse interaction. Yes, or or simply the risk of not achieving the therapeutic objective that we stated to the patient. Now, it's important. This is important because it's really different that you tried and failed in a therapeutic approach with the patient collaborating and taking an active role in the sustainment and proper procedure of the therapeutic approach. And the other one is that you tried, you failed, and the patient is not aware of this failure of the or this success more than, well, you did it, you are better, but with what diagnosis? What did you give me? What was the plan with this approach that you gave me? Why did you prescribe me this medication or and not the other medication my neighbor takes for the same problem? And it's our duty as medical personnel, as physicians, to tell our patients and to inform them of why are we doing what we do with their health. Okay, there are some basic pointers towards informed consent. Okay, it's mandatory. There is no excuse for the psychiatrist or the psychologist to not to explain what does he want to achieve with the patient. If the patient has a depressed mood, I need to tell him that my medication, that what I am prescribing is meant for him to sleep better, to have an improved mood, that it will take some time for it to set in the fact that the patient, that he or she will get better with time, but normally he will not be aware of this improvement in his symptoms, but perhaps his family, his friends, or his caretakers might notice the improvement before. Of course, I need the patient to know why this approach is the most favored option among the other options that possibly may be used to treat him or her. Of course, we have to be very thorough in the explanation of the risks and possible adverse outcomes of the intervention. Yes, there is a rule of thumb here, and that the duty of the physician is to inform about the mild or moderate risks or adverse outcomes that might present when the patient takes the medication, and that are frequent. But there is also a specific need to tell the patient about the severe or potentially lethal outcomes, and what might be even the symptoms that put the patient into alert of a risk of a severe yet infrequent outcome. Of course, in the medical record, we should be very specific in respect to the description of the capabilities of the patient to understand the information and take a proper decision based on this information. Most of the time, you'll see, or well, really frequently, you will see patients that because of his or her mental illness is not able to understand the information or to take a proper decision, at least when you start treating him or her. It's the duty of the psychiatrist and the psychologist to describe the situation and the reasons behind what is being described of a limitation of the patient in the medical record at the moment of the interview. Why? Because the informed consent is not, as I said before, is not a piece of signed paper. It's a dynamic process when I give the information to the patient constantly adapted to the changes of the patient himself or his situation, biological variables. I need to inform why I am continuing with the treatment or why I am changing it or why the diagnosis changed or how did the prognosis of the patient change in time. Yes, and this can only be given when I am facing the patient, be it presentially or in the now famous telemental health approach. Of course, among visits, there can be some kind of variation in the situation of the patient. And it's my duty as a psychiatrist to inform the patient what kind of findings I have made in this interview for me to take the decisions that I will take once I finish my consult, my interview. Okay. Excuse me. Seems that we have a problem. Okay. Give me just a minute, please. Okay. Okay. We're back. Sorry. Okay. There are some prerequisites to give consent in psychiatry. And Applebaum in 1982 gave us a roadmap of what we need to take into account to consider a patient able to give consent. First is the ability to make a choice. Can he affirm his consent? Can I tell him now the information, receive his input, and ask him later what he thinks about what he decided, and can he sustain his decision in the long term? Can he ask the proper questions when being informed? Can he express his doubts? Can he suggest any kind of modification or suggestion for the approach? Or can he answer properly to the questions that I ask him or her? If I tell him that I am going to project a psychotherapeutic plan meant to be taken in 6 sessions with the objective of intervening his fear of multitudes of open spaces, can he ask questions? Can he give me information to understand how can I tailor the therapeutic approach to his personal situation? Of course, Applebaum gives us a correlation about some problematic situations that may arise when you deal with this approach, with this requisite, when you are evaluating this ability to make a choice. Obviously, a mute patient cannot answer any questions and cannot understand any questions if this mutism is due to an auditory problem. be very careful with aphasic patients. And obviously, there are some patients because his or her mental illness will present with very or severely affected thought processes or content and won't be able to affirm the consent given the delusions, the hallucinations, the thought disorders, the the behavioral disorders. Of course, there is the other one, the factual understanding of the elements of consent. Can the patient understand what the intervention is about? If I tell him that I want to prescribe venlafaxine because he will be benefited of an extra push of noradrenaline in his brain, obviously this information uh, translated in a way that the patient can understand. Can he understand this? Can he understand and remember the risks, the probability of outcomes? Can he be careful when checking his blood pressure, his heart frequency? Or can he remember this when telling this information to his head physician, his internist, his surgeon when the time comes for a remission? Can he understand and partake in a discussion about the advantages and disadvantages of the intervention? And are there other therapeutic alternatives? Obviously, you might see that this factual understanding of the elements of consent is not really specific to psychiatry. It's very interesting because Applebaum geared these prerequisites to give consent in psychiatry, but not for the clinical environment, but the academic and research environment. But I think, and I hope you agree with me that these events can also be applied. These facts, these prerequisites can also be evaluated in a normal clinical practice. Of course, there enough elements of allo and autopsychic orientation to know for the patient to know who he is and why is he being attended by you or interviewed by you. If he does not have this element, be prepared. This patient will have severe difficulties to give a proper consent. Of course, this can happen in dementia, in delirium, intellectual disabilities. That's why at least Applebaum took into account. Of course, there are many clinical situations that may disrupt the factual understanding of the elements of consent from the patient. Okay. Now, the situation appraisal is the third prerequisite to give consent. Now, the patient can understand why he is in there, why the treatment will be given. You informed him properly, but can he understand the consequences of his decision? Can he have does he have an enough stable mood for him to take a decision, a proper decision in his benefit, in his true benefit? Or can the patient focus on the relevant aspects of the consent that are relevant to his own reality? Of course, Applebaum told us, be careful with the patients that have poor insight, that are in denial, and or are in a situation of helplessness, of perceived helplessness. Of course, I want you to take into account the patients that go for an interview to get attention from a specialist in addiction medicine, because most like there are many instances where the patient has difficulties taking this decision no matter what therapeutic approach is proposed, and take into account that as they may say agree or consent the intervention, they might um, revoke this consent very easily. So given this scenario, any kind of professional that is giving attention to a patient with a substance use problem must take into account this ambivalence, this high probability of revoking the consent against medical advice. Of course, it is virtually impossible to find a patient that has a full integrity of all these four prerequisites. But not only this allows me to to think about if I take the decision for the patient or if I rely the capability of the decision to a caretaker or to a family member, but also it helps me document the personal situation of the patient. And even if the patient is able to consent, even that he does not comply with all four prerequisites, it's my duty to record on the medical history that the patient has some prerequisites present or not, and why. Yes, this will be something that, in case of a lawsuit, will give some sustenance, some foundation to give the judge or the lawyers understanding of what steps were taking in deciding the therapeutic approach, or even why was taking the autonomy of the patient into account or not. Please, if you see that your patient does not comply with any prerequisite to give consent, make sure to re-interview him or her and to re-inform him or her about his clinical situation as soon as his clinical state allows it. And of course, make sure always take to heart that the informed consent is not a paper but a inherent process of the doctor patient relationship, and it's dynamic, it's always changing. If the patient improves his mental state, make sure to obtain consent once you are able to. Now, is there any way when I can take a decision or a therapeutic approach with a patient without informing him? None. There are no situations where the patient is not informed about a therapeutic approach. If you say the patient is absolutely disrupted behaviorally, it's violent, and it's not able to take a decision, well, cannot take a decision, but must know why he is being mechanically restrained. Why are you using injectable antipsychotics on him? This obviously accompanied with a de-escalation approach. And if not possible, once the patient improves, you have to tell him or her why did you do that. And also, you have to inform the caretakers or the family members when the patient is not able to understand the situation or appraise it or has a factual understanding of elements of the therapeutic approach, as I already told you. Now, there are some sins in the act of getting consent, some unforgivable mistakes that should be corrected by any professional that is providing mental health care to a patient. First one, that it's very frequent, is to delegate the responsibility to another professional. I have seen many hospitals that have general practitioners and psychiatrists in the same ward, and because of time constraints or the proper dynamic of the ward, the decision and the duty to inform the patient about what is going to be done with him relies on the general practitioner that normally has a longer stay at the hospital. Now, this is a problem because the general practitioner or the nurse of or the psychologist that works with the psychiatrist is not a mage, that does not have clairvoyance. So he or she cannot know beforehand what the specialist is trying to do with the patient or what's the rationality behind such decisions. If you decide to intern a patient in an inpatient ward, it's your duty to tell him before he is internet about why are you going to send him to an inpatient ward, for what are the symptoms that sustain his stay in a bed in a hospital. And there is no way that this can be done once the patient gets there. No. Automatic signing of the consent form. As I told you, the consent is a dynamic process of the doctor patient relationship. It's not a signed paper. You cannot take a patient and tell him, yes, please sign here and you will be prescribed. Sign here and we will send your family member to the hospital. No, you have to sit with the patient and his caretaker and inform him of the nature of the procedure or the intervention, of the diagnosis, because it's only ethical that the patient knows what he or she has, and that sustains a therapeutic approach, a continued visit to the doctor. Now, take into account that once you get the signature of the patient on the consent form, this is not a free pass to do everything you want. Modern theoretics of ethical procedures in informed consent tell us that every time you make any kind of change to the therapeutic regime of the patient, he should be informed and he should sign verifying that he understood what was being done, why was it being done. That's the fact with the signed paper of the consent. It's not the informed consent. The paper is not the informed consent. It's just the certification that the patient understood the diagnosis, that you told him or her what were you going to do, for what, and what were the risks that you were taking when formulating that such specific therapeutic approach. Yes, it's not one sign here and we will do everything we want. No, that does not work that way. Now, relying on the form, on the consent form, and not the medical record. This happens quite often all around the world. It's really problematic because the psychiatrist, the practitioner, the cardiologist, the intensivist, every doctor or medical practitioner commits this mistake. Once a consent form is needed and once the patient signs it, the physician forgets to document all the process and all the byproduct of the interaction between the doctor and the patient. And this is quite problematic because in this act of informing the patient and obtaining his consent, at least in psychiatry, we can get more information about the reality of the patient, of his or her capability to take decisions. And this surely has an impact on the outcome, on the adherence, or even in the diagnosis. And this should all rest in the medical record of the patient for future reference. now. In the world, informed consent is pretty much standard all around the world, but there are some differences. What we need to know is that the consensus regarding the components of informed consent are that obtaining consent can be bypassed in case of severe mental alteration in absence of a caretaker. Uh, think about it. You are in an emergency psychiatric ward, and the police just got a patient that had a seizure or that lost consciousness, and once he was delivered to the emergency room, the patient is disoriented, has slurred speech, is aphasic, has any kind of severe perturbation in his psychic state, in his mental state, that does not allow the patient to understand anything of what anyone is telling him or her, and they obviously to give consent to any kind of approach. Of course, in this situation, you must inform the patient once you are doing the intervention. The decision was taken by you as a professional, but your duty to inform the patient about what is being done still stands. Of course, a manifest emergency situation. Think about it. This patient is aphasic, is violent, or denies an intervention, but the patient just had a stroke, um, and cerebral infarction, and needs to be intervened by the neurologist. There is no way that we can expect the patient to revise the decision, to think and process everything about what is being done, or what's the plan, because we have a couple of hours before that brain area is lost. In this way, you should take the decision for the patient. You will inform him about what you are going to do, but you should intervene because it is a manifest emergency situation. And if you do not act right there, the consequences can be permanent and can be very disabling. Or that the patient is in an imminence of violent escalation of any kind of nature, and he becomes a risk for himself or for other people. In this scenario, we should intervene after the patient has been correctly contained in his violent escalation. We can inform him or her what we did and why we did it, and formulate any kind of plan to prevent the imminence of future violent events if possible, and to tell the patient, and obviously try to get his consent if it's possible. Of course, there are some situations where it's not the patient that is able to make the consent, but we have to delegate that responsibility into a caretaker. There are some situations in where, for example, among the family members, there are discrepancies and there are diverging opinions on what should be or should not be done with the patient. This is most true for psychiatry, where there is so much stigma. Obviously, this depends on each country and each legislation to to tell us who has the first word regarding the decisions that should be done with a patient that is not able to take a decision himself. In Colombia, the legal order of consent by proxy is first the spouse. After that, if not possible that the spouse is there or it's a widow patient, then sons or daughters of the patient, and finally the siblings. Obviously, regarding informed consent, this changes a lot when you are talking about pediatric population. But this is not the scope of this presentation. Obviously, child and adolescent psychiatrists must revise what are the legal criteria for informed consent, because we are talking about underage patients. In conclusion, please make sure to talk to your patient. The basis of a good therapy, of a good or at least acceptable therapeutic approach, lies in the capability of the professional to talk to his patients and to have communication continuously flowing. Please be very thorough in explaining the diagnosis and the implication at the end of the session. The patient should have a proper understanding of what's happening to him or her. It's not acceptable that when a friend or a family member asks the patient, "What did your psychiatrist tell you? What does he have?" and that the patient is not able, or the primary caretaker is not able to explain what the professional said. I had some situation once, some years ago, with a patient that went for a confusional state to many doctors, to many specialties. Everyone treated him, and all the people said he should go to a psychiatrist. He should go to a psychiatrist for treatment, or a psychotherapist, because he does not want to eat, because he is hostile towards his wife. And well, it resulted that when finally they went to the psychiatrist, to me, i asked I asked them, what did what was the diagnosis that was given to him? No, we do not know. Well, he's being treated for something, right? He has a prescription. Yes, he is taking some medication, but we do not know why or what for. The doctor just said that he had to take the medication as what's stated in the prescription. Okay, but what for, or what is the intention of this? No, we don't know. It resulted that the patient had a hepatic encephalopathy and was in a a very aggressive treatment for a portal hypertension, for a diabetes, and for a chronic hepatic insufficiency, and the family members did not know anything about it, and the patient was exhibiting mental changes in his mental state, because he was having a recurrence of a hepatic encephalopathy that was later treated by but it was important for for the family members to know this, for to have a quicker, a prompter treatment by a psychiatrist. Of course, the patient needs to leave your office knowing what's the plan with him or her, and write everything. In case of a lawsuit, we as physicians, as medical personnel, as healthcare workers, have no defense against a malpractice lawsuit. And the only defense we can count on permanently is the medical record. If the medical record is insufficient, there is no way to save the case. There is no way for the medical personnel
Just 1 minute,
explain.
please.
Oh well,
Just
is it
60 minutes
sorry?
already.
Oh yes, yes. Sorry, I didn't. No, it was so late. Of course, ask for consent for every intervention if possible. I already told you before. And read. Science is an ever changing thing, so indications, risks, benefits are always changing. Mechanisms of action or clinical indications for psychiatric prescriptions are always changing. So it's important for the psychiatrist to know what that medication he is prescribing does or what else can happen. And please do not experiment. One thing is that you are in a research scenario with controlled in a controlled trial or anything of the sort, and the other thing is that you are in your everyday practice. When you are in your everyday practice, you are meant to follow the lex artis. Lex artis is the term applied to what the scientific, academic, and professional community regards as good practice. Do not experiment, do not do things because it has always been done that way or because my teacher once told me that. No, you need to know what's current, what's the state of the art in your profession. Okay? Thank you for your time. I appreciate you for joining the Global Psychiatric Association First Inaugural Congress. It's been lovely to do this, and I hope you enjoyed this as much as we enjoyed providing you with these talks. And of course, make sure to publish in Global Psychiatric Journal and become a member of the Global Psychiatric Association. Many good things are to come. This is just the beginning.
Okay.
Thank you, Rainer.
Yeah, Juan, can we have a couple of questions from the more or less the internet? I think,
Yes, please.
and we have more or less some of mine. What's the relevance of the legal framework for getting appropriate consent? So one is about the value of the legal framework. The other thing is how can we prevent families or relatives to have their own personal interest, and that might affect the informed consent. And the question is it this consultant who is doing the treatment, or is it psychiatrist who should get consent? So there's three questions, so I can repeat them if you want me to.
Okay. There is a very interesting question you're posting in there, and is the personal interests of caretakers and families, or even strangers. I remember this Netflix movie about one person that acted as a legal caretaker and annulated any kind of autonomy of his patients that were all interned against her will. Oh, sorry, excuse me.
Yeah, are you there?
Sorry, I had some technical problems here. Okay, we have this problem, and this problem is quite frequent on addiction medicine because many times the patient is not sure, is ambivalent about his decision to take on a rehabilitation program, and it normally accepts an internation in an in a inpatient ward for because of the pressure that is being given by his peers, by his spouse, by his parents, mostly his parents. It's very common that their parents have unrealistic expectations about the intervention. And the only way to minimize the risks of a family member or a friend to intervene in the decision of the patient is to inform both, and obviously ask for the caretaker to keep silent while the patient takes a decision. Now, if they disagree between them, let them discuss the topic in private. What I do when I'm faced with this situation, when the patient does want to get treated for his substance use problem, and but in an ambulatory setting, and the family member wants to send him to a hospital for treatment against his will, is, well, you want to send him, you don't want to be sent. let's meet up in 3 days. Let's schedule an appointment in 3 days, and then you get to a consensus, and I am here to help you. Sometimes not intervening is a better choice than intervening against the will of the patient.
Can you just switch your camera on? And the second you answer, there was a question about the legal framework, and the last question was about, is it the treating doctor or the consultant? So if you can shortly answer that, that'd be great.
Okay, the first one was about the legal
camera,
framework.
If you put the camera on, you're not.
My camera is on.
All right, okay, that's fine.
I think that's because of the bandwidth or something. I do not know. I just turned it on again. Okay. What's the problem? The legal framework changes among countries. So it's difficult to tell you what are the parameters of the legal framework for all the world. Most of the legal framework derives from the chart of the rights of people with mental disabilities from the United Nations. That's like the most important document regarding the policies of informed consent in all around the world. But the specifics of legal frameworks vary among the countries. Like I will tell you something. In Taiwan has a very interesting culture because the patient, any kind of patient, but mostly the psychiatry, the mentally ill patient, does not have any kind of autonomy in his or her decision making. The decision making is the responsibility of the consensus of the family members, even if the patient has the opportunity on all the possibilities to make an informed consent, to give consent. So this is a country where all this protocol of respecting the autonomy of the patient really does not apply because of cultural and legal reasons. Argentina is another example, a very complex example. I invite the viewership, the audience, to check about the mental health law in Argentina. It's a very problematic law because for political and philosophical reasons, there are severe problems in what needs to be done when the patient is not able to take part in the decisions regarding his mental illness or his intervention. The state and this law makes it really difficult for mental health care personnel to take decisions against the patient's will when the situation demands for it. And this obviously is really problematic when, for example, you need to prescribe clozapine. Clozapine in Argentina needs to have the authorization from a judge for the lethal risks, even being such a good and important and necessary medication in many scenarios. Involuntary internations have to have the consensus of an organism called the órgano de control, the control organism of the mental health law. So you need the consent of a lawyer, of a state lawyer, to indicate an involuntary internation. That's really problematic.
Okay, thanks a lot. Is it Yazir? You wanted to ask a question? Is this correct? Is Yazir still on? Okay.
Can you turn your microphone on, please? I can hear you, Yazir. Your microphone in the lower left corner.
I think. Okay. I think we leave it for today. So I think it has been very interesting and very interesting talks for today. And I think we have to say thank you for Juan, for this very enlightening and very special and very detailed talk. I think I'm delighted that we have managed to get very, very important and very educational speakers for today. And I'd love to see you again tomorrow at 1 o'clock for the next and third day, the last day of the inaugural meeting of the Global Psychiatric Association. See you tomorrow. And we are very grateful if you come back and listen to the most important talks. Thanks so much. And I think, Juan, do you want to say some final words for today?
It's been a wonderful day, very interesting talks. We had the opportunity to have the view on the situation of home-based healthcare in Japan, which is a rare occasion. Normally, we do not have many information about what's the state of the art of mental health care in Japan. It was very interesting. Joao was a marvelous speaker, really enlightening about what are the opportunities for research in the future years to come. Well, of course, you, Rainer, I think your talk should be mandatory in any medical faculty. It's, I think it's the most basic of the basics about research. So I think it needs a lot more exposure, and I hope this event gives us the opportunity to expose your work to the world. And well, thank you for giving me this space to talk. Everything has been marvelous. I am very pleased with the experience today.
Okay. Thanks a lot. Let's close then.